now you're back. Or
Is that
how
back?
much snow did you get over there on the coast?
It's pretty gnarly. We got quite a lot. We had to cancel the last 2 days, and we're supposed to get 4 to 8 inches tonight. So,
Wow.
Ouch.
yeah, the
Right.
coastal region, it's not what you expect.
Yeah, especially on a day when I'm considering mowing the grass.
Yeah.
Right. All right. Happy to have you. All right. I'm wondering why Dr. Keith Bachman is on the list here. What is that? That's not right. He's supposed to be in Hawaii.
No, I'm here.
The party. He's here. This is his last meeting. Yeah.
Oh, okay. I was under the impression last month was your last meeting. Okay. I see Robert.
I wasn't planning to talk today.
Ah, okay. So Hawaii's next month then.
Yes.
Excellent. I can fit in a large suitcase, just so you know. Laura, I see Dr. Laura. All right, so looking for Sally. Sally, are you on? Susan Miller, are you on? I see Tony. Thank you, Tony.
Yep, I'm present and account for.
All right, Susan Miller, Sally, and Enrique. Enrique, are you here? Here. I see Enrique. So we're missing two now. Susan and Sally. Any are your microphones up? I still don't see you. All right. Well, if Susan and Sally show up, we are 2, 4, 6, 8, 9 out of 11. Clearly, no math required. We have a quorum. All right. With that said, let's get a move on. Let me move my screens around here so that all right, I'm going to call to order the Oregon Educators Benefits Board this fine February 4th, 2025. Time is 1 o'clock. We do have quorum present, and I will say any comments about the January 7th board minutes that are in your packet. Anybody have any comments? All right, if not, I'll take a motion to accept the board minutes as presented. Going once.
I
Still
move to
moving.
accept the minutes as presented.
All right, I heard
This is
Bonnie for
Bonnie.
the motion.
This is Cheryl Berger, I second.
I will second.
Okay, Cheryl got the second first before whoever was second, or whoever.
Sally.
Sally.
Sorry.
Oh, Sally, you're here though, right? Okay.
Yes.
Gotcha.
Yes, I
All
am.
right, no problem. All right, so we're still missing Susan Miller. All right, have a vote. All in favor of the motion to accept the board meetings as presented, please say aye.
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 All right. Anyone opposed? All right, we passed that, the board meets. All right, and we're already a minute and a half ahead of schedule. How nice.
Bill,
all right.
I
Go ahead.
didn't mean to interrupt you, but this is Susan Miller. I am here.
Oh, you are here. Okay, great,
Yeah,
great, great.
thanks.
Well, we are 100%, right? All right, perfect. Awesome. All right, so we are going to dive right into the topic of the year every year, renewal responses. This is round one of what is typically round 3 rounds of renewal responses till we get till April, when we go through the finals and approve the renewals in May or at the end of April. All good. And then, so we have a slew of people from all kinds of backgrounds working here. So I think, Kirsten, are you kicking this one off?
Hi, Bill. I am going to kick things off today. Thank you.
All right, you're on.
Perfect. Good afternoon, members of the OEB board. So today we're here to talk through the round 1 renewal responses. We have a little bit of a unique agenda today by design. So for the first 20 minutes, Mercer is going to talk at a high level about the round 1 renewal responses, the major drivers behind the renewal responses, and then also talk a little bit about the balanced framework approach that we take to achieving 3.4% each year. And then we're going to hand it off actually to Kaiser Permanente first and then MODA to talk through in more detail the justification behind their renewal increase and then answer directly any questions that you may have. Next slide, and we'll go one more. So although the discussion today is focused on the financial element of the renewal, the CIAO committee is hard at work discussing the clinical renewal initiatives that help achieve our goals of making our members healthier. In the March next month at the March board meeting, the CIAO committee will begin to bring forward to you recommendations for clinical initiatives that you could consider for the 25-26 plan year. Next slide. So we are working actually towards a beginning of April decisions meeting. It happens right away on April 1st. So today we're going to be reviewing the round 1 renewal results. There are 2 more rounds coming. The next round we'll talk through together in March. Those will be the round 2 renewal responses. And then the round 3 and final renewal responses we'll bring to you at what, Bill? Oh, we'll bring those responses to you at the April 1st meeting, where we'll also make our final decisions on what's going to go into effect on 10/1/2025. After decisions are made during that April 1st meeting, work kicks off both to update the contracts, and then of course the carriers and staff are all furiously getting ready for open enrollment and a 10/1/25 effective date. Next slide. So the round 1 renewal responses that you're going to see today, those reflect the carrier's initial proposals for renewal premium. They do not yet reflect the benefit of the evaluation and negotiation process that Mercer and the carriers and staff will work on behind the scenes. And as soon as we got the round 1 renewal responses in early January, after the board meeting, but in early January, we began working on evaluating the proposals that came in and identifying areas where we wanted to negotiate with the carriers, and have been doing that and will continue to do that over the next few months. So as we go through this renewal season, the round 2 renewal response that you'll see in March and the round 3 renewal response that you'll see in April, those will reflect the results of the evaluation and negotiation process that's been going on. Next slide. For all of us visual learners, this slide is a visual representation of how the carriers approach a premium calculation. And you'll hear a little bit more from Kaiser Permanente and MODA Health about how their premium was calculated. So we wanted to give a little bit of background before those presentations. On the left, we have premium this year, and on the right, we have premium next year. So starting with the small pink boxes, those are the non-claims costs portion of premium. The global name for that is retention, and retention includes carrier overhead expenses. It also includes regulatory taxes and fees, and then typically includes margin for adverse fluctuation in claims experience. The bigger portion of the premium this year is the claims cost in green. So I want to highlight for you that the pink bar, one, is a pretty small percentage of total premium, maybe around 10%. And also it's pretty flat year over year. So it's not a major driver of the premium increase. To calculate the premium needed for next year, the carriers will take the actual claims experience. So that's that green bar on the left, and they'll trend it forward to the next plan year. And trend is the annual increase in things like the cost of services, the number of services that OEB members are having, something called the mix of services, which says, hey, are members switching from or being moved from lower cost drugs, let's say metformin for the treatment of type 2 diabetes, to more expensive therapies for the same condition, GLP-1 drugs, for example. It's kind of a real live example of mix and play. Also, trend can incorporate innovation and new healthcare technology. So the carriers add that expected annual increase that we call trend to the claims experience to project next year's costs. So next year's premium then are the projected claims costs and the retention. And then from there, to calculate the renewal premium increase, we can take the required renewal premium divided by the current premium, and it will give us the percentage increase. And we're going to walk through all of those shortly. Next slide, please. This table illustrates, there's a lot of math on this table, but this table illustrates the final negotiated renewal increases, beginning with the 2021 plan year and going through the current 2024 plan year. So those are across the top, those are columns. And then we have the cumulative renewal increase, so the average annual increase through the 24-25 plan year, because those are all known. We have the round one proposed renewal increase, and then the cumulative average annual increase with that round one proposal included. And of course, it's just the round one proposal. We have a lot of time left. And then the rows represent the carrier and lines of coverage. So at the top two lines of coverage and carrier combinations are Moda Medical and Kaiser Medical. And together, Moda and Kaiser account for about 90% of the budget. So let's walk through these numbers together. The overall renewal for the 2025-26 plan year as of round one is 8.1%. And as is typical, the round one renewal is driven by what's happening in the medical plans because those are 90% of the total. So this year, the 8.1% overall renewal increase is being driven by the Kaiser Medical renewal increase of 13.81% and the Moda Medical renewal increase of 6.94%. So we can walk through those a little bit more in detail and then also cover the different lines of coverage. So the Moda Medical renewal of 6.94 is approximately a trend increase. The Kaiser Medical renewal of 13.81% reflects higher than expected experience so far during the 24-25 plan year. Both Moda and Kaiser have applied the trend guarantee credit. And then this year, we do want to recognize Kaiser and say thank you for recognizing the lower trend in reimbursement levels of Senate Bill 1067 and reflecting that savings in the premium increase. The Delta Dental renewal of 3.34% reflects expected underlying dental trend. The Kaiser Dental renewal of 7.5% reflects higher than expected claims experience in most service categories, including preventive care, fillings, and periodontics. The Willamette Dental renewal increase is 2.5%, which reflects trend plus positive experience. And then all three vision plans are renewing at a rate hold. I'll just pause there and give you a chance to digest this information and decide if you have any questions so far. Cheryl.
Thank you, Kristen. So just out of curiosity, when you look at your projected 25-26 round one, where were we last year? Do you remember what our first round looked like last year? Is this greater, less than, approximately on par? Thank you.
Yeah, your question's right on point. So yes, I do know. I think it's 7.1%, and it's in a later slide.
Okay.
Yeah, and
I can wait. I just curious.
No, it's all right. I have the deck open in another spot, and so I can let you know for sure. It was 7.1% last year and 5.8% the year prior for round one. So it has been trending up, and there are some reasons for that, which we will definitely get to.
Okay. Thank you.
Yeah, thank you. Mm-hmm. Tony.
Yeah, thank you. And if this is answered elsewhere in the slide deck, let me know. That last
Sure.
column of average increase of projected.
Yeah.
The definition of that in contrast to the projected 25-26 round one column that you just spoke to. I'm interested in the difference between the two. Again, I can wait patiently if it's later or take it offline.
Yeah, no, now's a great time, Tony. So let's look at those last three columns. The third to last average increase as of 24-25 looks at the cumulative increase over the time period through 24-25, and then we calculate what was the average increase over that whole time period. That last column, the average increase as of the projected round one 25-26 renewal increase, says, okay, if the round one renewal increase was the final increase and we stopped now, what would the average increase be looking back historically? And of course, we don't stop at the round one renewal increase. We keep going for rounds 2 and round 3.
That's a 5-year look back. Is that what you're saying? The average?
20. So it'd be a 5-year look back for the average increase as of 24-25, and
Okay.
then a 6-year look back if we include the projected 25-26 increase
Okay,
with it.
so that's where the average is coming from, the previous 5 to 6 years. Got
Yeah.
it.
Robert?
Robert.
So I'm the last column. I'm curious as to, in light of our 3.4% restriction, what type of guidance does that last column give us?
Yeah, I take that a couple ways, Robert. And now I'm wondering, and I'm interested to hear your thoughts too, if there's even value in showing the last column, knowing that with round 2 and round 3, we get to a lower number through a variety of factors. When I think about this slide, and we'll come to it in a few slides as well, but when I think about this slide and look at the cumulative increase, really what we're seeing is the value over the long term of Senate Bill 1067, and we can begin to compare the average annual increase for OEB to, say, the average annual increase in the commercial market, which I was just looking at, was 4.5% per year over this same time period. And we can see that OEB is performing better even with the round one renewal position coming in where it is at 8.1%, which kind of robbing a future slide, but it's relevant. The 2024 National Survey of Employer-Sponsored Health Plans also is projecting 8% renewal increase before plans for 2025 in the commercial market as well. So OEB is right in alignment with the commercial market and the headwinds that it's been facing recently. But even with that, historically, the average increase has been very low, better than the commercial market.
Soon to follow up. So I'm looking at Kaiser. If we had back in 2021 and beyond, set them at 3.4% rather than under 3.4%, then our 13.81 would be less.
It's a little, I totally understand why you would say that, Robert, because it's intuitive to think that for Kaiser, because their model is different than MODA, and they are a budget down model, it would potentially be a little bit different for them depending on what else was going on in the broader market. But I think you're illustrating a point, and the point is accurate. Ollie.
Thanks, Kirsten. Just a point of reminder that we talked about this a little bit at the retreat, I think last November, regarding the calculation of the 3.4% and the way the statute's written. It prohibits, a rolling average over multiple years, which based on board feedback, we wrote a legislative concept to amend the statute to allow for a greater test period, whether it be 2 years or multiple years, and how it's calculated. And we made it about a quarter of the way, and didn't quite get in the governor's budget. So yeah, this is something that we can continue to raise with the governor's office, with the legislature, because it really, as you see in the third column from the right, it really doesn't capture the years that the board was under 3.4%, and give the board the benefit when it's calculating, out in 2026. So that is a real challenge that we'll continue to raise the awareness level around. Thanks.
Thanks, Ollie. Next slide, please. We include this size to give you a sense of scale. We really notice two things about this slide. First, OEB's total healthcare budget for these included lines of coverage is over $1 billion now, 1.16 billion. And then you can also see on this slide how the medical premium, 769 million for MODA and 275 million for Kaiser, represent about 90% of the total premium. We have current enrollment over on the left. So there's about 58,600 subscribers currently enrolled in Kaiser and MODA Medical. Next slide. This is a slide from the 2024 Mercer National Survey of Employer-Sponsored Health Plans. So in blue, that's the actual or expected healthcare budget increase after plan changes. And then in purple, we have inflation. So just a couple things about this slide. The projected increase for 2025, and again, theoretically, we would know, right? Because we're post 2025, but it's because of the timing of the survey that we're saying it's projected. The projected increase after plan changes was 5.8% for 2025, actually 8% before plan changes. If we look back at that same 5-year time period, the average commercial increase after plan changes was 4.5%. The other really interesting and notable thing about this slide, at least from my perspective, is that you can really see beginning in 2021, coming out of the pandemic, that inflation and also premium increases have been both high and also volatile. And there are several factors behind this, and we'll talk about this on the next slide. So we just wanted to talk about some of the unique factors that have really been at play here with OEB. And I think going back to the 2019-20 plan year with the passage of Senate Bill 1067, we could never have foreseen that the pandemic was coming. And then after the pandemic, such extreme economic factors as well. But that's what's being illustrated with the green downward pressure arrows saying, hey, in the beginning, in the 2021 and 21-22 plan years, we had some tailwinds helping the renewal increases be low. Of course, there's Senate Bill 1067. We talk about that all the time. But then just from a financial perspective, there were some extenuating circumstances with COVID that led to a reduction in care beginning in early 2020, persisting into 2021, and that reduced utilization led to lower renewal increases. Factors started to change in the 2022-23 plan year. It was a transition year as COVID-related expenses increased costs, and also provider shortages led to longer appointment wait times. Inflation was really ramping up during this time period. And then beginning with the 23-24 plan year, we've faced a series of headwinds, including historically high inflation. We've had provider shortages coming out of the pandemic that have put pressure on wages. We've had increased utilization now because as we've increased access and gotten providers back into the clinic, which is positive. Of course, more open available appointments means that more appointments are being had. So we've had increased utilization, increased prevalence of chronic conditions. We've talked about that with you all before as well. All leading to upward pressure still so far, and Kaiser Permanente and MODA will talk about that with you a little bit more as well. I'll pause again before we go on. All right, so next slide, please. And we're just about done. But we wanted to reiterate to you this idea that there's an order of operations and that there are priorities when we begin to think about how we're going to achieve 3.4%, because we always have in our minds our members, our OEB members, and protecting them from premium increases, from benefit changes to the extent that we can, from the removal of any services that they're using. So there's an order of operations here. The foundation for achieving 3.4% is the evaluation of the renewal proposals as they come in and negotiation with the carriers to make sure that the proposals being offered are accurate and fair and reasonable relative to the level of claims costs that we expect to see in the OEB population. On top of our foundation of negotiation and evaluation, then we look to see, are there any efficiencies that we can put in place that help achieve savings by increasing quality or reducing low value care? After that, we look to available subsidies. Last year and the year prior, we had conversations around the rate stabilization reserve and whether or not some of the reserve should be used to help offset the renewal increase, essentially deferring it to a future year. John and I will talk to you more about that next month because it has some pros and cons to it, but it's certainly in the arsenal of available tools. And then lastly, we consider benefit changes as necessary to achieve that last final decrement down to 3.4%. And even when we do consider benefit changes, we've worked with you to develop a standard for doing that in a way that we feel is best for your OEB members. And that's on the next page. So when we begin to evaluate the trade-offs between different paths to achieving 3.4%, and we'll begin to have that conversation with you next month in March, any paths that include benefit changes need to adhere to these principles. And the first one is that the benefit changes need to be equitable, which means they need to be shared equitably across most members. So we don't want to put too much of the burden of benefit change on one specific group of individuals. And last year we achieved that with several small and distinct Kaiser plan changes. Second, we want to make sure that the benefit changes support the board's long-term strategy to achieve the triple aim. So we don't want to inadvertently roll back changes that have positive clinical impact to our members. And then lastly, we want to make benefit changes where possible that maintain OEB's competitive position in the market. It is one of our board goals to grow. So I'll pause there and see if there are any questions. Otherwise, that wraps up Mercer's portion of the hour. We have a couple more slides in this deck, but they're just informational only, documenting some of the assumptions in the renewal calculations, and we don't need to go over those today in detail. Little light reading for you if you get bored later. And then I want to make sure we save enough time for Kaiser Permanente and Moda Health. All right, well, thank you so much.
Okay, moving on to Kaiser.
All right, thank you, and good afternoon. I'm Jennifer Stacy. I really appreciate your having us today. I'm joined today by Dr. Keith Bachman, who you all are familiar with, and Wendy Watson, our COO and incoming president for Kaiser Permanente Northwest. Next slide, please. So, as Kirsten talked about, we are really navigating a complex and changing healthcare landscape, and we're focused on improving access, supporting changing healthcare needs of our members, and overcoming the financial headwinds that are buffeting our industry. We recognize the importance of delivering across that spectrum, as well as the cost growth constraints for this program. We'll touch briefly on cost drivers, our engagement with OEB members, and some of the things we're doing on our end to bend the trend, and then we'll be happy to take questions with the time remaining. Next slide, please. So first, I'll turn it to Wendy, who has led much of the work around our access and efficiency, so she can provide some perspective and context, and then we'll build on the discussion with OEB results. Wendy?
Yep. Thanks, Jennifer, and hi, everybody. So we wanted to make sure and start with a hit on access and what we've been doing and how this ties to cost. But we've been working very diligently on improving access coming out of the pandemic. And in the last 2 years, we've really seen some significant improvement in both primary care access and specialty care. So this has been a targeted effort on increasing our primary care clinicians so that our members have better access to primary care and are able to attach to a primary care provider. In the last year, we saw a significant increase in appointment capacity as a result of that work, which meant that we were getting a lot more patients in and more timely appointments. Our time to appointment in primary care is now back to what it was pre-pandemic, and we're still continuing to work on that to bring that in even more. Within specialty care, we've also been improving the ability to get into specialty care easily. So we implemented something called direct booking, and now over 50% of patients being referred into primary care, direct book from their primary care office straight into specialty care. So really easing that transition and reducing the time it takes to get into specialty. We've also done a big increase in convenient care. So we've significantly expanded our e-visits, which is a virtual way to achieve care, as well as Get Care Now, which is 24/7 on-demand virtual visits. Our e-visits we have available from 6 a.m. to 10 p.m. We have 7 providers who manage those e-visits coming in, and our Get Care Now is available 24/7. And we've gone from less than 9,000 in our first year to almost 100,000 visits per year now in Get Care Now. It's a highly satisfied service. And then urgent care as well, we've significantly increased the throughput in urgent care, 20% more coming through than in the pre-pandemic time. So how that's important is, one, I mean, the good side is we're improving time to appointment for our members. We are seeing member satisfaction with access improving. We're getting more preventative screenings done. So more patients are getting in, they're getting seen, and we're able to, really work on preventative screenings and meeting their needs. The downside impact on cost has been the more visits we see in primary care pushes more into specialty pharmacy, lab, imaging, and you see the cost increase associated with that. We've also seen significant demand increase. So we've seen a line of business mix, so more Medicare, Medicaid, which we tend to see higher chronic and complex members, which drives up appointment needs. We've also seen a really increase in weight management or visits for weight management. So in the last year, a 400% increase in patients coming in for weight management visit, which has really impacted primary care. And then, as Kirsten mentioned, there are certain areas where we have still continued to see staffing challenges on the clinician side, which has put pressure on compensation. So anesthesia would be one example where really seeing increased compensation costs. And then the pharmaceuticals as well. So definitely seeing more specialty medication indications. And again, as we increase throughput, more patients needing pharmaceuticals. So that's kind of just a super quick lay of the land in terms of all the work that we've been doing to improve access, but also how it's impacting cost of care. So Jennifer, I'll turn it back to you.
Yeah, thank you, Wendy. So then as we start to look at OEBB specifically, and if we'll go to the next slide, if you don't mind, through November of 2024, what we saw is that OEBB's total costs on a per member per month basis increased by about 17% year over year. This increase was similar across inpatient and outpatient care at about 18%. And then as Wendy mentioned, pharmacy costs are up about 12.5%. It's the combination of both that increased cost of providing care and the increased care demand from both a quantity and acuity basis that's driving these results. So both outpatient utilization and prescription utilization increased year over year. On the other side, inpatient admissions and days remained relatively flat, but the increased cost of care reflects those opposing forces of significant care interventions and improve efficiencies and site of care advancements. So if you'll go to the next slide, what we'll show here is, for instance, half of the PMPM increase for our medical and surgical inpatient care was driven by our ability to care for an extremely premature newborn and for a member that required a heart transplant. At the same time, the decreased cost of care in other areas like inpatient mental health and substance abuse, which are positively influenced by the better access for outpatient services, were driven down. So mental health visits on an outpatient basis per 1,000 were up about 17% year over year, and substance abuse was up close to 6%. Similarly, enhanced access to care has led to early detection and better management of our OEB members. And you'll see illustrated in the table, OEB member rates of certain chronic conditions are increasing. So overall, our outpatient visits per 1,000 across the spectrum, including medical visits, outpatient surgery, radiology, where costs were driven by mammography and radiation therapy, are up. And then these year-over-year results also reflect continued focus on COVID vaccination with the end of the public health emergency and the termination of government subsidies in mid-2023, and the impact of COVID on pharmacy as well, where Paxlovid alone accounted for about $400,000 in spend. Other significant drivers in pharmacy include specialty medications for cancer care and autoimmune disorders, both of which can really be in the tens and hundreds of thousands of dollars, but provide that life-changing, life-saving care for our members. So next slide. You know, we've talked about trends, and we know that many of these will continue, including the innovation and increased cost of prescription drugs, as well as some of the factors that occur from a demographic basis. We also know that affordability absolutely remains paramount. So when I came to speak to the board last year, I was clear about KP's commitment to drive efficiency and affordability. And obviously, we're still on that pathway as we work to continue to improve access and to bend that trend. But what you'll see here is that our 2025 trend is significantly lower than the past years, and that we continue to focus on that through innovation, efficiency, and quality, while not giving up that drive to make sure that our members receive the care that they need. And I'll go to the next slide. And I know many of you have seen this graphic many times, but I think it's really important because as we talk about how we will continue to improve all those areas and drive towards affordability, the integrated care delivery system, our model is really set up to control cost and provide that quality care. So with those challenges facing us, it really will take health plans, medical facilities, and physicians working together to coordinate that care while managing cost, utilization, eliminating unwarranted variation, and reducing redundancies. So I think in a good example of this, you saw in the earlier slide, we see a prevalence of hypertension increasing both in OEB members and really across the board. So here, through a variety of interventions, including pharmacy blood pressure clinics, remote patient monitoring, automated blood pressure reminders, and enhanced nurse visits to support medication compliance, we're really focused on leveraging what we see as that power of integration to support blood pressure control. And that's just one example, but it's really how we need to look at every single opportunity to make these changes. And as a value-based payment system, we're really incentivizing the right work in the right place at the right time to really drive towards those outcomes. So to provide a little more detail, I'll turn it to Dr. Bachman for the next slide, and then we'll close out talking about cost initiatives. Dr. Bachman?
Yeah, thank you very much, Jennifer. I just wanted to acknowledge just the benefit that we have of the care, being able to care for the OEB population over time, which is a population in general who are engaged in their health and are really great partners with our care delivery system in optimizing their care experiencing, avoiding long downstream costs when possible, and downstream morbidity by early prevention and taking advantage of those opportunities that we offer our members. OEB members get great quality care as measured by HEDIS with OEB-specific cancer screening metrics and other preventive care metrics being greater than 90th percentile. In maternity, over 95% of OEB members who are delivering get timely and appropriate prenatal and postnatal care, putting themselves above the HEDIS 90th percentile. OEB members take advantage of our online services, which we know make our care more efficient for them and efficient for us. So for example, About 99% of prescriptions are refilled online, and the mail order rate is 60%, which is well above all national benchmarks. Telehealth and e-visits are used commonly, and so those are ways of getting their needs met without using claims-based encounters. Below there's a list of the high volume of e-visits, which are algorithmically supported visits, at nurse advice calls, where the nurse has the access to the entire medical record and is able to optimize the advice given, point if needed, but often the advice really resolves the issue. And then the high number of other virtual encounters. And we did look at the percent of OA's population who are engaged with non-claims based care management encounters, and that's about 11%. So it's a high, just all this data indicates high levels of member engagement in a population that is works with us or works in partnership with the care delivery program to optimize outcomes. Next slide.
Thank you, Dr. Bachman. So, I know we need to wrap up, and I'd just like to end by really restating our commitment to you and your members. So we'll continue to partner and collaborate with OEB and Mercer during the renewal process to meet both the financial requirements and to provide unique and the rich offering for OEB members and their families. Every decision, every initiative, every action that we have is geared towards providing that highest quality care. And we're really aimed at not just returning to pre-pandemic levels, but really achieving higher levels of performance. And at the same time, we're tackling cost controls across all components of the system, leveraging technology to focus on our clinicians working at the top of their license and redesigning working care, not only to evolve to our current landscape, but really to take us into the future. So really appreciate the opportunity to kind of lay the base, open to have some questions, and looking forward to the continued conversation as we work through this renewal and future renewals.
Any questions from the board? All right. Understood. All right. Thanks for the data. That's very important. I believe we're moving to MODA next.
Good afternoon. This is Craig Anderson. I'm a Senior Vice President and also the Chief Actuary here at MODA. And I was asked to provide some perspectives around the round one drivers behind our renewal increase. And I think you heard earlier, Kirsten mentioned that this is just round one. These will be updated a couple times through the renewal process. And that's something that we work with Mercer collaboratively and get their feedback as we update the numbers through the renewal. So feel free to ask me questions as I go, but I'll try to leave some time at the end as well. Leave the next slide. So what I wanted to start with was just the renewal methodology and how we get to the increase that we presented in round one. We start with the base period information, which is our last full plan year with claims paid through November. That means there is some additional run out that we estimate in that base period experience. And also want to just remind you that we do credit 100% of pharmacy rebates in our base period experience that we use. We then try to project what the 2025-26 premium needs to be by including all the costs that we anticipate for that 25-26 plan year. So what that requires is us to trend the base period experience by 24 months. I'll spend some more time on describing what goes into trend later in this presentation. But we also include any state mandates or OEB approved benefit changes. It also includes our administration as well as taxes and an actuarial margin. And I do want to say that the margin, just to be clear about that, that's not a profit margin. That does not go to MODA, but that's a margin that's required for any uncertainty. When you're projecting out 24 months, there's some uncertainty, and we are entering a long session of the legislature, so we need some margin just to take into account some changes that might occur through that process as well. And also, we are crediting $1.9 million for the 2022-23 trend guarantee penalty. And that was done similar to last year's renewal. So all of that, when we do project the costs that we anticipate, we compare that to the current year premium, and we've established the 6.94% increase to our current year. Go to the next slide. So just to set some expectations about what we should anticipate with a renewal, if everything was priced perfectly, if we had the premium exactly set to where it needed to be in the current year, typically what you would see for a renewal is a trend increase, whatever's used for the underlying trend, with any adjustments for differences in benefits and from the prior year. So the underlying trend that we're using in this renewal is 6.69%, and that is the primary driver of the renewal increase in round one. And it's slightly above, the overall increase is slightly above the trend, and I'll explain why that's the case in a future slide here. And go to the next slide. So on this slide, I highlight some of the overall components that are built into a renewal. The first two, utilization and unit cost, that's really what drives trend, and I'll spend more time on that later. There are a few things that I want to touch on in this slide while I have it up. And the third bullet down is leveraging. So what leveraging is when member cost sharing is held fixed and overall cost sharing is increasing. What that does is it puts more pressure on what the plan pays. So the plan's paying the part of the overall cost that's not covered by the member. So if the member's cost sharing is staying flat, the plan has to pick up a leveraging effect of the overall cost increasing. So this is really what's driving the renewal increase above trend. And a way to address this is to periodically increase member cost sharing in line with underlying trend. There's also population changes that can affect the renewal. We don't do anything explicit for population changes. OEB is a fairly stable population. When people age off, there's new people that come in, so the average age doesn't change that much. So other morbidity changes that happen within the population also occur in trend. I touched on benefit changes earlier, but if there's any explicit benefit changes that occur or we know about, that also gets added onto the renewal increase. And there is some mandated benefits that occurred from the 24 legislative session that has about 0.25% impact on what we're projecting here for the renewal increase in round one. And then lastly, there's actuarial judgment that's used in setting some of these projections going forward, particularly around some of the factors. And again, that's something that we work with through the renewal process with the Mercer actuaries to refine those as we go. Go to the next slide. So I mentioned that trend is the biggest driver, and trend is made up of two components. One is utilization, so that's the change in services, the number of services that we anticipate for the future, and the other is unit cost. So starting with the utilization changes, the way we look at this is by major service categories. So you can see in this chart, we've outlined inpatient hospital, outpatient hospital, professional services, which include not only physician services, but ancillary services like labs and x-rays and DME and that sort of thing, and then pharmacy separately. So we look at these major service categories separately. And then to do a projection of what we anticipate for future utilization, we look at historical averages to see how they're how they're trending over time to set our future projection. And what I've shown on this chart is what we used for the 24-25 renewal versus what we're now using for the 25-26 renewal. And I just wanted to highlight a couple components here. One is the inpatient. Historically, inpatient services have moved to the outpatient setting as more things are being done on an outpatient basis. So if last year's renewal, we actually had a decrease, we anticipated a 1% decrease in inpatient utilization. But what we're seeing over the last 3 years is that that trend moving from inpatient to outpatient has flattened. So we're anticipating a flat utilization increase for inpatient. And then the other one I wanted to point out is pharmacy. As you can imagine, pharmacy utilization has increased over time as new drugs come on the market. New indications are made available for prescription medications. We used last year a 9.3% utilization increase for drugs. We've seen that that's started to moderate somewhat. So we brought that down to 8% on the pharmacy component. And then outpatient and professional, those have really bounced around quite a bit coming out of the pandemic. So we've left those at the 0.5 and the 1% moderate utilization increases that we had last year. You can go to the next slide. So the other major component of trend is unit cost. And I want to highlight that unit cost is not only the negotiated increases that occur with our network partners, but also this takes into account increases in intensity of services as well. As kind of it's blended in there as well as services become more complex as well. So there's some change in the mix of services that's accounted for in the unit cost. And the other thing that we do for unit cost is we break out those services that are impacted by Senate Bill 1067. And as a reminder, Senate Bill 1067 set a cap for some inpatient and outpatient hospital services at 200% of Medicare for primarily the larger hospitals in the state of Oregon. So we look at that separately because the unit cost forecast comes from a different source for that. And then pharmacies broken out separately here. So what I want to say about this is that the top line, which is really for Senate Bill 1067, those unit cost increases are established by CMS, or the Centers for Medicaid and Medicare Services, which is a federal agency. Those historically, or at least in the recent history, had been higher than previously because of the pandemic. And what we're seeing going into 25-26 is those unit costs are coming down by the federal government. So that's helping for those services impacted by Senate Bill 1067. Same for what we're seeing with negotiations and for the increase in intensity of these services. That's come down a bit going into 25-26. And then on the flip side, we are seeing an increase in the unit cost for pharmacy services, and that's built into our overall trend forecast. So you can go to the next slide. So this is my last slide, and this is bringing it all together for the trend. And as I mentioned earlier, total trend is a combination of utilization and unit cost. So if you look at the last 3 columns of this chart, what I'm showing here is utilization and unit cost are multiplied together to get a projected trend. So you can see that, for example, the unit cost of 3.87 for medical, when you add the utilization piece, the overall trend is a little bit above 4%. And you can see that that's how the projected trend is calculated for each of these components. And then for each of the components, we then weight those based on the proportion of claims that are covered by each of them. So you might find this interesting, but those services that are covered under 1067 make up about 22% of overall medical and pharmacy costs, because again, that just covers inpatient and outpatient services for those hospitals covered by Senate Bill 1067. And then the medical portion is about 57%. That's the non-Senate Bill 1067 medical. And pharmacy has grown to be about 20% of the overall costs. So we weight those together based on all those proportions to come up with an overall trend of 6.84, which is, as I mentioned earlier, the primary driver of the renewal increase. One more thing I want to say, a couple of things I want to say about this slide before we leave it is that as the non-Senate Bill 1067 costs increase at a more rapid rate than the Senate Bill 1067 cost, the protection that Senate Bill 1067 provides starts to become less and less because it becomes a smaller portion of the overall weighting. So it's just something to keep in mind of the impact of Senate Bill 1067. And then to get our final trend that we've used in our renewal, we have taken into account the transition of Humira to a biosimilar medication, and that did impact a portion of the 24 months that we use for the overall trend. So that's how we came up with a 6.69% overall. So that's what I had to present. Hopefully that was helpful, and I'm happy to take any questions you might have.
Just to be clear, and I guess I could have asked Kaiser the same question. These numbers are based on CSL or what us politicians call current service level, no changes in benefits?
That is correct, except for any benefits that might have been mandated by legislative change.
Yeah, understood. But basically none of the optional things that are being researched, right?
That currently correct, yeah. And that's, I think I caught a portion of what Kirsten was talking about earlier, but that's what we work through over the next few months is to pull some of those levers to get us to closer to what we want to get to at the final outcome.
Ollie?
Yeah, thanks, Craig. So one of the few exceptions that the boards get outside of the 3.4% are any changes in state and federal taxes and fees. Did you assume any increases at all to the like premium tax or provider tax or the PCORI fee?
No, those are the same as what are currently in place. I believe that both the premium tax and the provider tax are up for renewal in this legislative session, but we anticipate that those will go forward as is with no changes.
Thanks.
That's the taxes in the OCA, the original OCA bill, right?
Premium tax, yeah.
ACA, right?
Provider
The
tax
Affordable
is
Care Act.
Provider tax is state level, and that's
okay.
That's kind of one of the reasons our legislative concept. It wasn't good timing because of the provider tax negotiations. So those will be occurring here, have been occurring, but will really ramp up here as legislative session.
Got it. Other questions from the board? All right, so baseline starting numbers, essentially current service levels plus mandated changes.
Correct.
So may the tug of war begin.
Look forward to it.
Yeah. Okay. With that said,
thank you.
I don't see any. Yep, I don't see any hands up. So we'll roll right in to the well-being survey results with. Let's see who we're dealing with here. Mercer.
Hello, and this is going to be a tag team with Teresa Cross and myself. I'm Stephen Neldner from Mercer, but Teresa Cross, the wellness coordinator, is going to begin.
Hello, OEBB board. It's nice to be here, and I'm happy to share the results of our well-being survey that we conducted last year. And as you just heard, we're joined by Dr. Stephen Neldner from Mercer. And I believe that Pete Rotigliano, who is from Mercer and also helped out with this, the data analysis, is here with us to answer questions too. So what we're going to cover today is we're going to talk the background about the survey, when it was fielded, what it looked like, how it was promoted. We're also going to share with you some overall survey results. Most specifically, the things that we learned from our members through the survey that the board would be most interested in and things that the board probably would have the most influence over. The survey was quite large, covered a lot of different areas, but we're just going to focus on a few things today. We're going to, one thing that's missing from this slide, I just realized, Dr. Neldner, is the demographics. We'll also share with you what the demographics of the respondents looked like, so you get a picture of who responded to the survey. We'll look at benchmarks because the survey results were compared to Mercer's database of results from different industries. We're going to look at uniquely scaled items, the recommendations that are coming out of the results, and the overall summary and findings. Next slide, please. So I'm going to start on the right-hand side. Was there a question? Okay. Our survey covered several different domains of well-being: social, emotional, physical, financial, and spiritual, intellectual well-being. We contracted with Mercer to conduct the survey. The survey was 79 survey questions. In addition to that, there were 41 demographic questions. These are the real D SOGI: race, ethnicity, language and disability, sexual orientation, and gender identity questions. These are required. We are required to include these on all surveys that we field. This survey was the first time we had done one with our OEB members. And so this is serving as a baseline. We wanted to identify what's going well, what our members are struggling with, and identify opportunities for how we can better support their well-being. I mentioned benchmarks a little earlier. When we dive into the results here in later slides, you will see that our results with our members are being compared to those that are benchmarked of other industries that Mercer tracks. So this will be the global results, benchmarks, United States benchmarks for people working in educational sector and also in public sector. And being as this was the first survey, we will use this as the baseline with which to look at future survey results and hopefully see improvements. Next slide, please. So how the survey was conducted. This was during a 7-week period last year from April 3rd to May 24th. Mercer sent emails to all of our members that we had emails for. They were provided with a link that they could then access the survey. Posters were also created by our communications team with a QR code so members could access the survey. Those members who don't usually use email could access the survey that way. The response rate was 11%, and out of almost 68,000 members who were invited to participate, a little over 7,200 did. And we'll see when we get to the demographic page slide that even though the response rate was a little low, we feel that those who did respond are representative of our members as a whole. We worked really hard at confidentiality. We know people are concerned about that, especially when they're being asked about health, personal choices, identity, that kind of thing. So Mercer collected all of the data. No one within OEB saw anything. We also set a threshold of 200 respondents, meaning if there were fewer than 200 people who responded to a question, or if there was an organization that had fewer than 200 members or fewer than 200 responded to the survey, we would not see those results. And that was a way to protect confidentiality. We've since then learned that there is guidance to help us analyze survey results from smaller numbers, and we will use those in the future. But because this number of 200 was the one we've used in previous surveys, that's the threshold that we maintained and promised to our members this time. The survey included mostly quantitative questions, but there were several qualitative questions where members could enter their own responses. No one within our organization saw those verbatim responses. Instead, Mercer grouped those into themes. Next slide, please. And here's the demographics that I mentioned. So with respect to gender, age, race, ethnicity, and residential region, we didn't see large differences. Slightly more females or women participated in the survey, and members who were a little older than the membership responded to the survey. But those weren't big differences, and those weren't things that we saw that were outside the norm. So we're confident that the 7,234 members who responded to the survey are representative of our membership as a whole. Next slide, please. And this slide is kind of cueing you into the next section that Dr. Neldner is going to cover. But we've color coded things to give you an indication of what's going well, what's not going well. So we will see results in green that indicate that we are doing well in that area, and we will continue to do what we're doing. The yellow is kind of that caution sign that says we could be doing better. Those are opportunities for improvement. And the cranberry color there, that is, the red stop sign that we all know of, is where it tells we better pay attention here. We've got some opportunities to improve. So I'm going to turn it over to Dr. Neldner, and he's going to dive into the specific results.
Thank you for setting that up, Teresa. And again, thank you to everyone on the board. We have broken these different results in the bar graphs you'll see in the next few slides up by different dimensions. Teresa mentioned earlier the different dimensions of well-being that we considered in the survey, and you'll see at the top of each slide what that particular domain is. So we're first going to look at physical well-being, and I'll repeat what Teresa already mentioned, is that we narrowed the focus on the questions that we're going to report on to those that are most likely related to benefits. We realize that the OEBB board doesn't have control of everything in the workplace and everything that happens in people's lives. Your primary opportunity is for those things that relate to the benefits that you provide. So we've narrowed the question field to those. Just again, to give you the lay of the land here, and you can see the legend at the top of the slide. The green responses are favorable. The amber or gold are neutral, and the red are unfavorable. And we've also included the average responses by manager and non-manager, as you can see in those line graphs. So now we're looking at individual questions. And again, maybe starting with the overall commentary and observation that overall scores were fairly good for the overall health and seeing their provider regularly. And for the most part, around 3/4 of the population say they do have a trusted healthcare provider. We do see some scores that are below benchmarks, and we're going to drill down into those on a future slide where we'll actually compare the results to those benchmarks that Teresa mentioned earlier. So let's go through the individual questions. Question 43, I usually get enough sleep to feel rested and healthy. About half the population says that they are. That's probably lower than we want. We know that's the quality of sleep and the duration of sleep is an important element of overall health. And we'll come back to that later. Excuse me. About 60% of the people who responded said that they believe the benefits they get from their job help them feel good and stay healthy. Only about 12% say that they don't. And then you can see that about 30% were neutral. And on this question and others, it's sometimes difficult to interpret what neutral really means. It could mean that they haven't even used those benefits, so therefore they're not responding. So it's difficult to attribute a positive or negative reaction to those in gold, those in the neutral responses. Moving on to question 50. I have a healthcare provider who takes care of my health and I trust them. Again, that's a good high rating, 72%, and very close for managers and non-managers. 77% say they go to a healthcare provider regularly to make sure that they stay healthy. And another very good response is 77% of respondents said that they believe that their overall health is good or very good. And then the last question on this slide, 61, I have a health condition that needs medicine, checkups, and or treatment on a regular basis. This is termed a reverse response question. But if you look at what we really want to take away from this one is roughly 54% of people said that they had that condition or had a condition or needed regular checkups. And we included this slide related to benefits because it does point to the fact that there are people in need of healthcare and other medical benefits, and medical benefits are probably important to them. So a reminder that that's something that the board does have responsibility for, and And I know that you're always committed to delivering the best that you can there. We can move to the next slide, please. So moving to, excuse me, emotional well-being. And again, benefits related questions. About half of members feel that they actually understand their mental health benefits. And only about half of members feel that their mental benefits do help their mental health. So looks like an opportunity to help more people, and we're going to talk more about opportunities and recommendations at the end, but pointing out that there's probably an opportunity to help people better understand what they have available to them and how they can use them. And I do see a hand up, so I'm happy to pause and have Michelle comment.
Yes, thank you. I think what would be helpful to see in this data is like of those who answered that they know how to find and use OEB benefits to help them take care of their mental health. We want to know from those people specifically if the benefits, if they feel like those benefits help them take care of their mental health. You know what I mean? Like I'm just kind of confused about these two slides or these two questions side by side, because I'm wondering if people who don't understand how to use their benefits are also answering that their benefits, you know, they're neutral. They're not sure if their benefits help them. Do you know what I mean?
Yes, no, you're right. That the neutral responses are difficult to interpret for sure. We don't know what that means. If they don't know how to find them and use them, then on question 39, they may just say, well, I don't really know how to respond to that because I don't use them. So that's a possible explanation there. Another speculation and possibility, and I should probably say, first of all, the nature of the question and this selection of responses doesn't allow us to really fully interpret all the connections and all the causative elements of healthcare and the accessibility or availability to it. But one of the things that we discussed internally and with staff was that the fact that about 51% say that the benefits do help them. It could be that same 51% that actually realizes how to find them and use them. So if an equal number of people who are finding them and using them, knowing how to find them and using them, feel that favorable toward them, that could be relatively positive. But again, we don't have enough detail about what those neutral responses really could mean. I think it's favorable to say only 14% don't believe the benefits that they have help them. So that's could be interpreted as generally positive.
I think that's true. But if the 14% who responded unfavorable were in 51% on question 38, that's a problem. And so I know, like with SurveyMonkey, you can slice the data. You can say, like, we want to look at only people who answered favorable on 38, and then we want to see how they answered on question 39. Do you know what I mean?
Yeah.
Yeah. We have that capability. In fact, actually, I'm looking up right now. I don't believe the response rate was that different between the two questions. So that would mean if the same number of people are responding to both questions, we could pretty much assume that it's the same people. So, you know, I know how to find. A lot of people don't know how to find. But the other thing we should keep in mind is we typically don't look into mental health care unless we want mental health care. So I see these numbers are actually pretty good. I wish more people knew about it, but in general, the people who know about it think that it's basically giving them pretty good care. But I'm double checking that number right now so I can confirm with you.
Thank you for that, Peter.
Yeah, sure.
I also wanted to remind everyone that when the survey was fielded, which was last April and May, OEB had a different employee assistance program than they have now. As of September, members have access to, or October, members have access to Canopy. And we, staff and Canopy, have been working hard to promote the program, conducting all kinds of, providing lots of opportunities for folks to learn about Canopy services. So we see this, while, you know, maybe not so great last year, we see it as the baseline and certainly room for improvement. And we hope we see more people using or understanding and how to access their mental health benefits next time we ask.
And Peter, by the way, that's Dr. Peter Ritigliano who chimed in there, who is looking at the database right now. Peter, do you have that answer, or shall we move on and you can chime in when you
Move
find
on.
it?
I'll make
Okay.
a reference once I find it. It shouldn't be long.
Excellent. And I know we didn't answer your question specifically yet, but do you have any follow-up questions based upon our conversation? If not, we can move on
Oh,
and
thank you.
come back to that once Peter finds the answer. All right, we can advance to the next slide, please. Moving to the domain of emotional well-being, and again, benefits-related questions. Overall, about half of the members feel that they understand, oops, sorry, I didn't advance. Financial well-being is the next domain that we're looking at. Less than a third of the members feel that their financial benefits really help them manage their money better. However, 75% of the people feel that they already manage their money quite well. And then there's only about a quarter of the members that feel that they're putting away enough money for retirement. And then probably the last two questions, as you can see in the text, indicates that financial issues could be getting in the way for some percentage of the population that might affect their decisions about whether or not to pursue healthcare. So let's look at these individually and see what the data actually tells us. So number 67, question 67, benefits my job gives me helping me manage my money well. 31% say that, 27% say probably not. A large number are neutral with that on that particular question. But in contrast,
I do. I'm just turning.
someone have a question? So 66, I feel I can manage my money well. So this is probably could be informing some of the other responses, but a large percentage, almost 3/4, think that they are already managing money quite well. So does that mean they don't need help from their benefits to help them manage money? Again, not hard to really determine from the responses because we had a lot of neutral responses there for question 67. Question 68, I'm confident that I'm putting away enough money for retirement. And you can see that a large number of the population, over 50%, I don't think they're putting away enough money, and 23% are neutral on that, and only 23% are saying that they feel confident that they're putting away enough money for retirement. One of the things that we talked about here with staff is the idea that because you have a state retirement plan, retirement system, there's apparently confusion among employees about what their retirement benefits really are, and maybe that may be part of the challenge for people to really understand if they can rely entirely or much to a high degree to their retirement benefits, or how much more they need to save on their own. So that's probably contributing to that question. Question 69, I sometimes don't get the healthcare I need because I don't have a lot of money. So 62% say that are respond favorably there, but 22% are saying that they may be avoiding care because they don't have a lot of money.
And so this is a negative question. Is the colors flipped here?
Yes.
So you're saying 22% responded in the affirmative.
22%.
It's a negative question.
Right. Right. The favorable responses are 62%. The unfavorable are 22%.
I can see that, but it says I sometimes don't get That means 62% said I don't get, or 22% said I don't get.
Peter, do you want to comment on that? I think it's the favorable. Go ahead.
Yeah, it's actually, you know what? I have to double check that. I believe it's the 62% say that they do get the medical care that they need, but it should say reversed in there.
It should say
I'll double
reversed.
check
The
that
same
now.
thing with the next question is a negative question as well.
Yeah, agreed. Yep.
And Pete, you can confirm,
I'll
but I
check
think we, in the bar graphs, we want to show the favorable responses in green consistently. So, but Peter will check on that.
Yeah, I'll check that.
And we'll come back to Peter on the outstanding questions. Are there any questions, other questions on this slide before we confirm those and respond to that last question? Now we'll move on to the next question, next slide, and talk about the 3 questions that we do have benchmarks on from our national database. And you heard earlier from Teresa that we have a rolling 5-year database, about 2 million lives a year are in that database, coming to that database. And you can see that there's a global mean for clients across the globe. US, obviously from the US only, educational mean, and then a public sector mean. In all these cases where we do have benchmarks, and by the way, there is one external norm for question 43. That's an actually directly from the NIH regarding sleep. So let's look at that one first. Against the US global mean, the Mercer global mean, 50% saying they get enough rest and sleep is 16 percentage points below the global mean in the Mercer database. And I'm sorry, that's from the NIH government database. So 16 points below the NIH's benchmark for getting enough sleep. Moving to question 49, the benefits I get from my job help me feel good and stay healthy. These are all from the Mercer database. You can see that against all the benchmarks, there's a reasonable separation, lower than benchmark for all the means, and in particular against the public sector mean. Education mean, you're about the same as for the US and the global mean. And then finally for question 68, I'm confident that I'm putting away enough money for when I retire. And we talked about that question and how people might be interpreting that relative to their understanding of their retirement benefits. But against the global mean, about 24 percentage points below, US mean 25 percentage points below, and the educational mean 19 percentage points below the benchmark.
Steve, do you want to just really quickly go to the previous slide? They were reverse scale. For some reason, the text didn't show up. I don't know why that is. And then going back to the other 2 questions around emotional well-being, I checked the N sizes for that, and the difference was a difference of 20. We had 7,204 questions for, I would feel.
Peter, you're breaking up.
Oh, I am?
Yeah.
Yeah, go back to the previous slide, just real quick, one more slide, the emotional slide.
Yep, you're still breaking up. We're having difficulty hearing you.
Peter, you could always put your answer in the chat for us if your audio isn't going to work. That'd be helpful. Thank you.
That's what I'll do. Okay, thank you.
Okay.
So before you lost him on the next slide, I thought he said that the way we interpret that is 22%, or basically a quarter of our survey respondents do not feel they get, sorry, on the next slide, do not get, or they need, do not get the health cares that they need because they don't have enough money. That's 22%.
Correct.
And Peter, similarly for question 70, it's 28% of the people that say they sometimes have to give up things to help them stay healthy.
Yes.
I mean, I realize that's the smallest number, well, not the smallest number, but that's a large number, but okay, got it.
And the next following slide, Peter also checked as well. I'm sorry, the previous slide. The other direction.
You guys hear me okay now?
Still fuzzy.
Type it.
He's typing it in, sorry.
Can we press on while he's doing that?
Yes.
Or is that the end?
So let's move on then to the slide after the benchmarking slide, which titled Uniquely Scaled. Correct. Thank you. So this slide shows a variety of responses. Again, reminding us that there were 7,200 total respondents on this particular question or set of questions and responses. Individuals could select as many responses as they wanted to. So we received 6,200 responses, but again, they could have chosen multiple answers to this particular question. So probably the most sobering one is the first one. I'm not familiar with any of these programs. Almost 50% of people said they weren't aware. The second bar shows that roughly 19% of the population who responded said none of these programs are helping me feel good and be healthy. And then we can go down the line and see that relatively low percentages of people are saying that these various well-being programs are helping them feel good and be healthy. Any questions on this slide? And then we can go back to what Peter has provided in the chat. We're going to talk about opportunities in the following two slides. So we'll be putting a point, an underline on some of these and talking about what is already being done and what can be done in the future. So let's go back to the questions on previous slides. Thank you. Oh, slide 38 has, in the previous slide, next slide, I guess it is. I'm looking for the one that has question 38. There we go.
Yeah. Can you guys hear me okay now? I switched.
Yes.
All right. I switched microphones. Yeah. So bottom line, looking at questions 38 and 39, the number of responses was 7,180 for question 38, 7,146. It's extremely unlikely that those represent significantly different populations given the total N size. So we can assume that pretty much everyone who knew how to find the mental health care were pretty happy with it. And really the biggest issue is around people not knowing about the program rather than the quality of the program. Sorry that took so long.
Thank you, Peter. Okay, I'm sorry to have you jumping around here with the slides, but we can progress now to the slide where we start to talk about recommendations. So overall, general well-being, the opportunities that we identify are almost 20% report that benefits offered to them do not help them get healthy or feel good. Also, about half of members reported not being familiar with most of the well-being programs offered by OEBB. And that does align with some previous survey findings. On a positive note, going forward, OEB's communication efforts have shifted to raise awareness of well-being programs and point solutions. One example of that is the distribution of monthly newsletters that's going to occur throughout 2025 that will be focused on health conditions. And each edition is going to include a summary of well-being resources by that condition that's highlighted in that particular issue. So we recommend that these kinds of efforts continue. Another area of opportunity that we highlight could be creating training for people managers to help raise awareness. We know that for the most part, managers are trusted by their employees in their work group to be a good source of information, trusted source of information. So leveraging managers would be another opportunity. Under physical well-being and benefits, highlighting the strengths, first of all, noted again that 72% trust their healthcare provider and 77% of respondents feel that their overall health is good or better. There are still some opportunities. Overall utilization of wellness benefits is low, as we saw in the previous slide. And many members do not feel that benefits help them feel good and stay healthy. Only half are getting enough sleep. And again, as noted, taking some action now on communications efforts will be shifting efforts to communicate what well-being programs and point solutions are available to people. And we recommend you continue to address or at least consider addressing other services that might address some of the needs of the population as we've identified in the survey here, like sleep. And I think we want to be sure that well-being content is easy to find on the OEB website and find other ways to communicate, whether it be peer-to-peer or entity by entity. It could be very different. We know we have lots of different entities that may have different modes of communication and cultural indoctrination. So we know that there are probably some opportunities that vary by different entity. Next slide, please. Emotional well-being benefits, opportunities, only about half of members know where to go for mental health benefits, and half feel benefits help with their. So again, we just confirm that it's very likely that the same number of people that are finding and know where to find their health benefits feel that they're helping them, but there's still a large opportunity for almost half the population to better understand what they have available to them and how to access it. So again, those communications efforts that are already started will probably help to direct more people to the services around mental health and other point solutions that are available to them. And again, we encourage trying to find additional ways to make it easy to find these resources on the OEB website and any other avenues of communication that are available. And to restate the importance of potential importance of people managers being another good source of trusted information, and consider developing toolkits and resources for them to use as well with their workforce. And finally, in the area of financial well-being, 75% of people feel that they manage their money well. But on the opportunity side, financial well-being benefits are only helping about a third of members, according to what they're saying. And less than 25% feel that they're putting away enough money for retirement. So why we emphasize this is that when people are worried about finances, it creates stress and anxiety, and those can impact physical health, emotional health, and well-being overall. So if there are opportunities, we think that there may be opportunities to help broaden financial wellness training available for all stages of life. We know that people's needs change throughout life. It can range from college debt to retirement, but even day-to-day expenses and managing budgets, all those different areas of financial well-being are important to different people at different times of their life. So consider a more comprehensive approach to financial wellness support. I'll pause there on the recommendation pages before we move forward with an overall summary. Any comments or questions?
Don't see any. You're about 5 minutes out.
Okay, we'll move quickly. Next slide, please. This slide is an overall summary. So This now is moving away from just focusing on benefits-related questions, but we thought we'd want to give you an overall view as well. So just to give you the lay of the land on this slide, you'll see that we've given you an aggregate score, percentage of favorable responses, and looking at social now as an example, 70% in all of the questions that relate to the social domain were favorable responses. Below that dimension score, there's a star that shows those questions that had favorable responses, more than 50% of the population responding. And you can see for this, I did along well with people that I worked with, 91% said that. The caution sign, that triangle below, those are responses that less than 50% of the population responded to in a favorable way. So at my job, we have things to do that we do together, like as a team. Some examples there, only 42% of people said that they had that experience in their workplace. So that's how those dimensions are constructed, and you can see for financial, 46% favorable. And we just went over some of the reasons why. That's the lowest scoring domain of all. The spiritual, intellectual, 65% favorable. And people feel like things that they do at work are important and make a difference. But flexibility is probably not as much as they'd like to see in the workplace. Physical dimension, 67% feel that they have a reliable way to get to work. 98% say that they have a reliable transportation or means of getting to work. But the work I do can be tough on my body. And this is another one of those reversed. Almost 30% of the people say that work is hard on their body. So that's a physical challenge. And then emotional well-being is the second lowest dimension of all. About 50% have favorable responses. 62% say they can handle their personal stress without getting worried or upset. But only 33% say they would feel okay talking to HR team if they had questions or felt worried about their mental health. So to end in this slide with some positives, team members feel that they have good working relationship with their coworkers, and that greatly contributes to their social well-being. And in the work environment, members feel supported at work, and they feel that they fit in and can belong. So for the sake of time, I'm going to hand back over to Teresa to wrap this up.
Okay, there's a quick question in the chat about, is there any ideas on improving the survey 11% response rate?
Yeah, thank you for the question. We were all hoping for a greater response rate as well. I have some thoughts. I think that we can work through, engage our trusted servants, our OEBB wellness champions, some of those folks who are in regular contact with people in the schools, even some of their union labor organizations and professional organizations could also be assist in promoting the survey. So those are just some ideas I have. And being as this was the first survey, we'll have hopefully more familiarity amongst our members next time, and we might be able to capitalize on that as well.
Yeah, one of the things we noticed, if people feel like results were taken as, actions were taken as a result of the survey, it typically leads to more people taking part in the survey. If people don't feel like they're getting anything from it, they're typically not going to respond to it. So that's one thing. The other thing I would strongly recommend is that given the amount of unions, bring them on board earlier in the process to talk about it. And then what they will do is, if we say, hey, we're going to ask these questions, we want to make this a better place for people to work, a lot of times they're like, great, let's push this on our people, and they'll talk it up from their perspective. So that's another option we could use.
Thank you, Doctor. Well, let's go on to the next slide. I know that we're running out of time here, and thank you for keeping us on track, Bill. These are the different domains, 3 of the 5 domains that Dr. Nelner just covered: the social, physical, spiritual, and intellectual. So some of the highlights are listed here and bolded. We know that members feel connected to one another. They feel like they're part of a team. They struggle with around questions of harassment and discrimination. Unfortunately, you know, the OEB board doesn't have direct influence over those kinds of work conditions. However, the fact that folks indicated those were problems tells us a little more about why their mental and emotional health may not be as good as it could be. Certainly, work conditions are going to affect one's mental and emotional health. People are satisfied. Back to the physical well-being. 3 in 5 members report that their benefits help them feel healthy, that they have a trusted healthcare provider, they have someone that they can turn to for support. And 3/4 of our members are going out into nature once a week, and half are getting physical exercise, physical activity. The spiritual and intellectual results, it is not surprising that people working in the school system feel that their jobs give their lives meaning and purpose. It really is a calling to be a teacher. So I'm not surprised at those results. People, only half feel that they're involved in decision making. The scores were low in terms of questions around whether the workplace, you could make a mistake and learn from it, or whether it was not a place where you felt comfortable making a mistake. And 3 in 5 people felt leadership at their entities, at their organization, recognized good work. Next slide, please. And then those last 2 domains that we've covered that are opportunities here, emotional well-being and financial well-being were 2 of the lowest rated aspects of well-being according to this survey with these members. Only half of them would feel comfortable going to their manager, and even fewer would be comfortable going to HR. We don't really know the reasons for that unless some of the qualitative comments spoke to that, but that's also an opportunity for us to help managers and HR benefits folks understand the programs and make sure that they're able to get those materials and program information out to their members. The financial well-being, while only 1 in 4 felt like they were confident saving enough for retirement, only 1/3 felt like they were being paid fairly for their work. We do know that a lot of people across the country were concerned about the economy. And so some of these findings were in light of that larger phenomenon. So we weren't surprised at some of the findings in that respect. Next slide, please. I think that's actually it. Yeah, okay. Any additional questions?
Floor is open. All right, a lot of very interesting data there. A lot of things to gel around. Some things standing out, but certainly good points to ponder as we take our work into the renewal cycle on how the data will reflect on our conversations. All right, with that said, let's take a 9-minute break. So be back at 2:50, please. We'll crank it up with GLP-1s. 2:50.
Thank you.
Sarah, are you with us?
I am.
So what's the core component of this new pain thing? Is it plant-based or is it synthetic?
Oh, the new non-opioid pain reliever. I
Yeah.
believe it's a synthetic.
Okay, interesting.
And it's the first of its kind. It looks to be at least not inferior to opioids for pain relief for post-op. But they've only studied it in 14 days.
Yeah, I understand that.
But it,
Yeah, I saw
you
that.
know, doesn't have the addiction potential.
I was just wondering where the base core molecule comes from a worm, 12,000 feet deep in a volcano tunnel, heat tunnel, or
Don't
what?
think so.
Right.
And now you've got me curious. I don't think so. I think it's synthetic.
Okay, interesting. Anyhow, it's 2:50. Let's get everybody back together. We're going to talk about GLP-1s, everybody's favorite commercial, right? All right, let's kick it off. Go ahead.
Yeah, okay, thanks, Bill. For those of you who don't know me, I'm Sarah Drake. I'm the pharmacy specialist on the Mercer team.
Can you hold on, Sarah, for a second?
You bet.
Sandy, you raised your hand. Did you mean to raise your hand? Oh, it's
No,
down.
sorry.
Never mind. Okay, sorry. Keep going, Sarah.
Okay, well, either way, Sandy or whoever else, we do want this to be interactive. So I encourage you, raise your hand, stop me, ask questions, and we'll make this an interactive discussion. But like I was saying, I'm Sarah Drake. I'm part of the Mercer team, and I support both OEB and PEB from a pharmacy perspective. So today I'm here to give an update on the topic of GLP-1s and specifically GLP-1s that are marketed for treatment of obesity. As I think many of you know who were involved in the board last year, this is a topic that both the board and CIO spent a significant amount of time on in 2024. The rationale for this updated presentation today, I'd say, is twofold. First, we know that this is an important topic. We know that members are asking for coverage of obesity treatment and specifically are asking for coverage of GLP-1s for obesity treatment. So we know it's important. And then secondly, we want to use the time to provide an overview of what's changed and what hasn't changed since last year. And we're asking the board to reaffirm the decisions that were made on coverage last year and make sure we're aligned as we continue to seek options to find coverage in the coming years. So there's a lot of material in this deck, so let's get started. So let's go to slide 4. This is just a quick review. What are GLP-1s and how do they work? So GLP-1 stands for glucagon-like peptide 1 agonist, and they are a class of drugs. They're indicated for the treatment of type 2 diabetes, and they're also indicated for treatment of obesity. And they work by increasing insulin release from the pancreas. They delay the digestion of food, and then they also work in the brain center to decrease appetite. They're also being studied for several other conditions, and we'll talk more about those in a little bit. But what that's going to do is expand their use significantly over time. One thing that I think is important to note here is that the OEB plans do currently cover GLP-1 for treatment of type 2 diabetes. So there's already utilization of GLP-1 in the plan. I think both Moda and Kaiser would tell you that GLP-1 is part of what's really growing that pharmacy spend. And that is generally for people with type 2 diabetes. Let's go to the next slide. And so this is some new data from the Mercer 2025 employer survey. And so what our survey does is we survey our employer clients to get general idea of their coverage. And one of the questions that we asked this year was around coverage of medications for treatment of obesity. And we had the ability to slice the data to look specifically at government employers as well as state government employers, and then employers that are in the West region. In all cases, these are employers that have at least 500 or more employees. And what you'll see in each of these pies is the gray. That is the gray part of the pie is those are employers that currently do not cover GLP-1 for treatment of obesity and are not considering adding coverage. The light blue is employers that don't currently cover it but are considering adding it. And then the green slices are employers that currently are covering for treatment of obesity, either with or without some special requirements. So I think that the important thing to note here, and this, it did take me a little bit by surprise because we hear so much about weight loss drugs, treatment of obesity, that actually more employers do not cover weight loss than do cover weight loss, especially when you look at both the government and the state government. I wanted to pause here, see if there were any questions or comments, or if anybody else was surprised by this data. Michelle.
Michelle?
I'm curious how you would, where do we fall in this? Are we not considering, or are we considering?
Yeah, that's a good question. I guess I'm not sure how they responded in this survey. But I would put them either in the gray or the blue. I would say OEB and PEB are both considering, but the decision was made last year to defer. You'll see based on the renewal and some of the numbers, we're recommending to continue to defer, but we're asking the board to reaffirm that decision. Did that answer your question?
Yes, thank you.
Let's go to the next slide. I wanted to bring up a couple of cases that have hit the news over the last several months. And these have been just highlighting some of the challenges that other state governments have faced around coverage of obesity treatment. North Carolina, we talked about last year, they eliminated coverage in April of 2024. Due to cost, they had nearly 25,000 members that were using the medications, which came out to about approximately 3.5% of enrollees, which is actually kind of around the minimum of what we would expect for the number of people using GLP-1. Their costs accounted for about 10% of their overall prescription drug costs, and they estimated that the cost to continue coverage were going to be about over $48 per member per month. More recently, we saw Colorado. Colorado began covering GLP-1 for obesity treatment in September. And unfortunately, they also found that the costs were unsustainable. In the 6 months, July through December of 23, the costs were $1.5 million. In 2024, the costs were up to $7 million. And the state had to make the difficult decision to eliminate the coverage when used for obesity treatment only effective July 1st of 2025. They're still going to allow coverage for type 2 diabetes, the cardiovascular risk reduction indication, which we'll talk about, and obstructive sleep apnea. But the coverage for treatment of obesity, they had to end. And I think this just highlights some of the challenges that, state governments and all employers are facing, where you can add coverage. If it becomes unsustainable, then it's a very difficult decision to make to eliminate the coverage after members have already started therapy. Any questions, comments there? Had anybody else heard that news on Colorado? That was pretty recent. That was announced. Let's go to the next section and talk a little bit about pricing. So on slide 8, what this is what the current pricing is for the GLP-1s that are used for obesity treatment. The bad news is there hasn't been a lot of change since last year. The only change of note is that Zepbound, which is made by Lilly, actually took a 2.5% price increase on January 1st, 2025. Otherwise, the pricing and the available rebates that were that are estimated by our market source really haven't changed. So we're kind of at the same
place for pricing as we were a year ago. What does that mean as far as what coverage would cost for OEB? Let's go to the next slide. So what we've had quoted so far by the carriers, MODA has quoted 2% minimum premium impact to add obesity treatment coverage. And that would be according to the FDA label. So people with BMI of 30 or BMI 27 with a weight-related comorbidity. And then Kaiser has quoted a 1.06% premium impact to add what they call the weight loss rider. Excuse me. And then the coverage would be based on Kaiser's eligibility criteria. Any questions there on the cost impact? The next slide, we won't spend a lot of time on, but what this is it just gives an idea of, even though the list prices are in the range of, over $1,000 to $1,300 a month, the manufacturers are offering direct-to-consumer pricing, either via a copay card or Lilly offers Lilly Direct through telemedicine. Unfortunately, even with these direct-to-consumer savings programs, the price is still often too high for most people to pay for out of pocket. The range from the manufacturers, it typically is between $400 to $650 per month. Okay, any other questions or comments on pricing before we talk a little bit about the new indications?
Hi, Sarah.
Lara.
This is Dr. Lara. I was just wondering, with all this number, if we have some projection data for Oregon, what is going to cost with patient numbers and kind of this price range?
Yeah, so the premium impact on the previous slide, if we go back, so those were based on some of the typical assumptions around uptake of people who would might be likely to use for obesity treatment and the current pricing along with available rebates or discounts. So about a 2% premium impact for MODA, 1.06% for Kaiser. Did that answer your question, Dr. Laura?
No. Actually, I was looking more broad information regarding diabetes and obesity in Oregon, and then how much money is gonna cover that with our plan. So that will be no specific for more like Kaiser, because you mentioned Colorado. So I'm trying to figure out is that is gonna be doable for Oregon, right? So with the population that we have with obesity and diabetes, is that gonna be doable for Oregon? That was my thinking.
Okay. I believe we did ask the carriers in the renewal, and Kirsten can keep me honest, to quantify the cost of both the GLP-1, projected GLP-1 for diabetes, for type 2 diabetes impact, as well as the projected cost for the new indications that would include both the cardiovascular risk reduction and the obstructive sleep apnea. So that was something that we asked for in the renewal request.
Thank you.
Let's go to slide 12 and talk a little bit about some of the new indications. So there's two new indications beyond type 2 diabetes and treatment of obesity. Wegovy received back in March of 2024 a new indication for what's called secondary risk reduction for people who have obesity or are overweight and have established cardiovascular disease, meaning that they've had a prior history of a heart attack or stroke, or they've got symptomatic peripheral arterial disease. And so that indication was approved. It does offer a risk reduction benefit. Unfortunately, the cost of this is challenging too. We've seen some estimates. The cost to prevent one major
additional cardiovascular event, meaning a heart attack or stroke, it's about $3 million at the current Wegovy price. So you have to treat a lot of people in order to prevent one event. But nonetheless, there is a risk reduction, and that is how the medication did receive FDA approval. Let's go to the next slide. Once Wegovy did receive this new indication, we saw some new CMS guidance. And even though OEB isn't subject to the CMS guidance, this is intended for Medicare and Medicaid, it's kind of important to understand what's happening in the market with Medicare and Medicaid. So the guidance that came out following Wegovy's new indication was that for the first time, Medicare was allowed to cover Wegovy, even though federal law prohibits Medicare Part D from covering what they call weight loss drugs. CMS is saying that medications that are approved for additional indications beyond just obesity treatment itself can be covered by Medicare. So that's a change. So that means that Part D plans this year in 2025, many of them are covering Wegovy for the cardiovascular risk reduction. At the same time, Medicare told Medicaid that they were required to cover the new cardiovascular indication. So Medicare was allowed to, Medicaid was required to. After this happened, we saw another new indication from another GLP-1. So if we go to the next slide. So Zepbound, which is Eli Lilly's GLP-1 that's marketed for treatment of obesity, it received an indication for treatment of moderate to severe obstructive sleep apnea in adults who have obesity. And what this one found was in the clinical trials, people did lose an average of about 45 pounds or 18% of their body weight. And those individuals experienced a significant reduction in their sleep apnea symptoms or their breathing interruptions during sleep. And when the FDA released that they had approved this, they did specifically call out that the improvement in symptoms is likely related to body weight reduction to Zepbound. Clinical guidelines for obstructive sleep apnea, they typically recommend conservative therapy first, then mechanical measures like CPAP or BiPAP. In many cases, this Zepbound treatment would be used along with existing conservative therapy or CPAP or BiPAP. It's not intended to be a replacement. It's another tool to, over time, hopefully reduce individual symptoms to the point that they wouldn't need the mechanical measures. So where are we in terms of what the OEB plans are covering now for the new indications? Let's go to the next slide. So currently MODA, the Wegovy is available via prior authorization for the cardiovascular risk reduction indication, and that was effective in September. In addition, Zepbound will be available through prior auth for members who meet the requirements for obstructive sleep apnea. As we've heard from pretty much all carriers out there and PBMs, both of the manufacturers of Wegovy and Zepbound are not offering any rebates or any discounts unless the carrier or the plan cover all the indication, including obesity treatment. Under the Kaiser plan, Wegovy can be covered for the cardiovascular risk reduction indication if the Kaiser provider deems it medically necessary. And Kaiser is reviewing the new Zepbound indication with their formulary committee, and there's not a decision on that yet. So that's where we are today. So there is some coverage available for GLP-1, both for type 2 diabetes and for some of these new indications as well in the existing OEB plan. What's not currently covered is GLP-1 for treatment of obesity without one of these other FDA-approved medications. All right, the next section we can go through pretty quickly. So this is the pipeline section. The important thing that I want to note generally in this section is that few things. These drugs are being studied for more indications, including, as you can see here, there's some additional cardiovascular indications There's metabolic associated liver disease, and then there's even some studying on Alzheimer's disease and further out potentially addiction. And so as those additional indications gain FDA approval, what we might see is this stepwise approach to coverage, where over time, additional indications will mean that more people in the OEB plan could qualify for one of these GLP-1s. And that could happen without the board taking any additional action. If we go to the next slide, this one, I just want to highlight that there's more GLP-1s coming. So, Zepbound and Wegovy, there's also Saxenda are available today for obesity treatment. There are more in the pipeline. There's one that could potentially be approved in 2025, but then we've got several in the pipeline for 2026 and beyond. So what we know today and what's available today as tools in the toolbox is going to change a lot over the next few years. And if we go to the next slide, this one just highlights some of the activity in the pipeline beyond GLP-1. There is a lot of research going on treatment of obesity. A lot of different mechanisms of action are being studied for drugs. And so you can see just the number of drugs in the pipeline by all of these different mechanisms of action. We could see a very different treatment landscape 4 to 5 years from now than what we're seeing today. Okay, let's go to the next section. And I just want to share some new real world data on both the prevalence of obesity as well as some new real world data on the use of GLP-1s. Excuse me. Getting over the flu still. It's done a number. Anyway, so on this slide, I call this one the good news, bad news slide. What this is some new obesity prevalence data that came out late last year in a pretty large study. And so the good news is if you look at the prevalence of obesity in Oregon versus the rest of the US, Oregon is doing better in terms of they have a lower prevalence of obesity in both adolescents and in adults than the rest of the US. The bad news is even though Oregon is doing better, by 2050, the prevalence of obesity is still expected to exceed 50% of the adult populations for both males and females. Also good news, bad news. Some bad news you'll see is, the percent change in the prevalence of obesity from 1990 to 2021 has really been staggering, not just in Oregon, but in the rest of the country, near 100% or more. And really some of those numbers for the growth in obesity for adolescents are really giving a lot of people pause. Good news is that the percent change projected between now and 2050 is slowing down, but that's still a really strong rate of growth. And so part of the conversation, right, we're talking about GLP-1s, treatment of obesity, both through drug and non-drug treatment, like Christy talked about Mighty earlier today, or some of the other weight management programs that are available. We also need to talk about how can we continue to pursue wellness and prevention of obesity. Any questions or comments on this slide and some of the data that's out on the growth in obesity? Let's go to the next slide and we'll talk about some of the new real world data that we're seeing. So this first study, this was a new study. It came out in Nature, and it was looking at more than 2 million individuals that were in the Veterans Health Program. These were people that were using GLP-1 for diabetes. And what the researchers did is they looked over this long period of time, people that were using these GLP-1s to identify what were the effects on some of their other health conditions. And so, some of the really exciting things that came out of this study is they found that people who were using GLP-1 for their diabetes did have a reduced risk of neurological disease, including Alzheimer's, substance abuse, and also seizures. There was a lower risk for blood clotting disorders, cardiometabolic conditions, and respiratory issues. And those are all tend to be conditions that are associated with obesity and diabetes. A few surprises came out. What the researchers also found was that the use of the medications were associated with a higher risk of GI disorders. That wasn't too much of a surprise based on what we know with some of the side effects of these medications, but also a higher risk for kidney stones, pancreatitis, and arthritis. And I think more research is needed to better understand, what's happening there and why are people who are using the GLP-1s getting more arthritis than people who are not. Next slide, this is some real world data that came out of Prime Therapeutics. And this was looking at people who were not using GLP-1s for diabetes, but were using GLP-1 for treatment of obesity. And what Prime Therapeutics did is they identified members in their claim database who had a BMI of 30 or more, and they had a diagnosis of obesity and were prescribed a GLP-1. They were matched with a control group that had similar characteristics in terms of gender, age, and other diseases. And then they looked at, what effect did the use of the GLP-1 have on overall medical spending over time. And it was a 2-year study. What they found was that the total cost of care for new GLP-1 utilizers was about $7,000 higher than non-GLP-1 utilizers in year 1, and about $4,000 higher in year 2. And the reason it decreased in year 2 tended to be that a lot of people actually discontinued the GLP-1s and didn't continue. So the cost of the drug went down. Unfortunately, this study in real world did show, I think, what a lot of us kind of knew already, which is that even though there could be savings in medical spending over time, that savings is probably going to happen over a much longer time horizon than 2 years, right? If you can decrease cardiovascular events, if you can reduce weight, over time, you can get some savings in medical spend, but that doesn't seem to happen over a 2-year period. In fact, we saw increased costs. Other interesting thing here was that after 2 years in the Prime data, only 15% of members were still actually on GLP-1 therapy, 85% discontinued. Okay, let's go to the next section and talk a little bit about equity. So we always want to think about equity in everything we do for OEB. And a few things to highlight here. What we found is even in plans where there is coverage available, there has been a difference in prescribing of GLP-1s for obesity treatment and for diabetes in some groups. And so we've seen inequities in the use of GLP-1 among Black, Latino, and Asian patients, as well as patients that have lower socioeconomic status compared to higher socioeconomic or white patients. And in fact, there was even in the Veterans Health System study, they saw that, and of course in the VA study, there's rich benefits for everybody, but patients of Hispanic ethnicity had significantly lower odds of receiving GLP-1 treatment for type 2 diabetes compared with non-Hispanic patients. So there does continue to be some equity concerns around how the drugs are prescribed and who gets access to the drugs. We go to the next slide. In addition to some of the prescribing differences, there's also challenges around plan design. Sometimes members that have higher deductibles might have a disproportionate financial impact. And of course, this applies more than just GLP-1, but the cost of GLP-1 can really concentrate that effect. Also, we've seen there's challenges around the social determinants of health, the prevalence of obesity, and some of the tools that might be available for prevention and treatment of obesity based on where people live, whether or not they have access to nutritious foods, and what kind of stressors might be part of their life. Let's talk briefly about the supply of GLP-1. So we can go to slide 28. So much of the discussion over the last couple of years, there's been a lot in the news around the manufacturers not being able to keep up with demand. And so we really didn't have a good sense of what the uptake might be of these GLP-1 drugs for treatment of obesity, because really nobody could even find them at their local pharmacy. Some of the good news here is that the manufacturers have significantly ramped up their capacity. Wegovy, which is the same drug as Ozempic, all strengths are being reported as available today on the FDA shortage list. And Mounjaro and Zepbound, also that shortage has been noted as resolved. But I think due to some legal action having to do with compounding, which we could get into if you want, the FDA does have kind of a long message on their website, letting people know, even though the shortage is resolved, there could be challenges on a pharmacy by pharmacy basis in terms of finding available medication. I'm going to pause here and just see if there's any questions or comments on supply, on pricing, before we quickly take a look at what we've been monitoring as far as point solutions, and then what our approach is around the renewals.
The equity slide you had previously was based around diabetes 2 patients getting access to GLP-1.
Right. Yep. So I don't know that we have data yet on the prescribing by different demographic groups for the GLP-1s for treatment of obesity. But what we have seen is even for treatment of type 2 diabetes, there seems to be some equity considerations and some differential of prescribing.
Thank you.
Good question. Okay, we can go to slide 30. And this slide I bring up just as just to highlight all of the different point solutions, all the different vendors that have stepped in to what we're calling the cardiometabolic market. So 5 years or so ago, there was maybe a handful of vendors that were in this space. With the additional interest in metabolic health, and the availability of GLP-1s for treatment of obesity, we're seeing more and more of these vendors coming in. So the Mercer team is continuing to monitor all of these new vendors, continuing to look at potential solutions, for treatment of cardiometabolic disease and obesity. One thing that's been really interesting over the last couple of years is the number of vendors that had previously offered either cardiometabolic solutions, telemedicine solutions, are now adding a GLP-1 module to their offering. There's definitely a lot of interest and different companies seeing an opportunity in that space. Okay, let's go to slide 32 and we can talk a little bit about the renewal approach. And we definitely want to hear the board's feedback here. And so our approach has been to monitor for readiness. And what we mean for that is we are looking for an opportunity to add broader coverage for GLP-1 for treatment of obesity when the pricing can become sustainable for OEB and when it can fit in with renewals. So as part of the renewal process this year, we asked the carriers to provide estimates for adding weight loss coverage, including GLP-1 and non-GLP-1 medications. We asked the carriers to provide estimates for implementing obesity treatment coverage for only the highest risk members. We also asked for estimates on implementing obesity treatment coverage via a point solution like one of those we saw on the earlier slide, or a lifestyle management vendor. So a more concentrated set of providers as an access point for GLP-1. And where we're going from here is we're continuing to ask questions, go back and forth with the carriers, continuing to monitor the GLP-1 market, kind of the broader treatment landscape for obesity, cardiometabolic health, and explore additional options as they become available. But at this time, we are recommending remaining with the status quo until an avenue for sustainable coverage is identified. With the caveat, as I described earlier, as more of these indications are being approved by the FDA, you're likely to see coverage just be increased incrementally as more people become eligible for treatment through those additional indications. So with that, I wanted to pause and we want to hear from the board members on this approach, this monitor for readiness approach, and remaining with the status quo for now.
Enrique.
Yes, Enrique.
Thank you, Bill. First of all, I appreciate staff and Ali for bringing this up. I know I emailed Ali if we could add this to the agenda because I had a couple members asking, one from Central Oregon, one from Portland area. So I have the information to go back. I personally think it's the right approach on the renewal process, and to hear more evidence and more sustainable path, but I'm also willing to listen to my colleagues who are on the board and go from there. Thank you.
Floor is open for board member Cheryl.
Thank you. I too really appreciate the time and the information that has been shared here today with regard to the GLP-1 and the use for, well, the multiple uses that it's available for. I concur that taking a cautious approach and listening and looking for a for sure message, I guess, if you will, to go out to the folks that we're working with and help covering. I think the worst possible message would be to take this on and then have to take it back. I think that just would not set a good feeling for the people that we work with. So I like the approach and I support where we're going at this time. Thank you.
Michelle.
Well, I don't know if this is coming up for a vote, but I just want to say that I'm going to vote my conscience on this because I don't think it's right to deny people groundbreaking medications that work because of cost. It's an impossible, and it's like we're forced into making a decision that feels to me immoral, honestly. And I know it's not the fault of anyone in this room, but it's our broken healthcare system. And I hate that we're in this position because I've heard from so many people who are desperate to get this medication because of all of the problems, both physical and emotional and mental health wise, that obesity is causing. And to be told that we have this thing that works, but no, you can't have it, it just feels awful.
Other board members? Robert.
Yes, thanks. So I appreciate the slide that showed the percentage increase, what that would represent. I think it would benefit us if we could translate in that somehow into, for example, our deductibles and maximum out of pockets for everyone would have to go up by this amount in order to cover GLP-1 drugs. The percentage, I get it, but until people see what it actually is going, how it's going to affect their individual plans, I mean, it's hard to measure the appetite. Sorry for the pun, for the GLP-1 drugs.
I think it's good that we've added these three options into the renewal letter for each carrier to give us these three cost estimates that you see at the top, the first primary bullet there. So we'll be seeing those numbers coming in when we get to the round 2 renewals.
Thanks.
Other board members? Tony?
Thank you, Bill. Your comment there a moment ago in terms of the renewal letters, will that data set that Robert was just speaking to, will some of those questions around impact to plan cost at the member level be included in that?
Absolutely. You will see how much percent adder for these three options is what we're requesting our carriers to provide. So when we look at the 3.4%, we'll see it in hard numbers, but in the end, we come down to the 3.4%, and you'll see some value of, this is not a real number. So 1%, right? If we cover adding weight loss coverage for all GLP-1 over whatever the label says is the minimum BMI. So you'll say, okay, 1% of that. Now, I think you'll see, based on current stuff going on in the healthcare industry, we're going to come in above 3.4% most likely. I'm not predicting that. Well, I am predicting that, but I'm not guaranteeing you that. But we'll likely start at a higher number than what we're allowed to spend. And so it'll be difficult to add a higher, more, or without trading off other things, which trading off other things includes two parts: our reserve fund or our out-of-pocket maximums. And you'll be able to trade those off when we get to actually round 3. Misty, you're giving us some feedback somehow for some reason.
Yeah, I don't know what button to push
Okay.
here, Bill. Can you hear me?
Let me finish Tony.
Yes,
Let me
we can
finish
hear.
Tony's thing. Or Tony, did that make sense, Tony?
What's
Great.
that?
Sorry, hold on. Tony.
Yeah, it does make sense. And though we haven't spoken to it, I guess I'm just assuming in all of this is those increased costs be borne across the membership.
All members.
OEBB.
Yep. All employee members will distribute cost, right, on various plans, right? All right, back to Misty.
Yeah, I think just to piggyback on Tony's there, percentages, why we have to think in that model while we're making these decisions, I think the communication out to our members has to be in dollar signs for this to understand the impact. Literally how many dollars it would cost each member more in order to do this.
Yeah, those numbers will be in, especially the round 3. You'll see each plan, its monthly estimated payment, and what its out-of-pocket maximums will be. In the end, we can look at all that and jostle them all around, but the final number we have to get to is an average of all those plans at 3.4%. Some plans may go up 5, some plans may go up 2. The average of all plans needs to go up no more than 3.4%. And those values are there, but I'm just saying that's the final answer. You'll see all that stuff in the charts. It's just you're going to see a lot of numbers, and you will. We have to metric them down.
Right.
To one
I'm
value.
talking, Bill, when we communicate out to our members to make it as simple as possible so they understand that if we did this with GLP-1s, it would impact them by having to pay $153 more a month. That simple, not all of the confusing data.
Yeah, and again, there's options that this board will choose on how to offset that blob and dollars per month, right? It won't be a straight translation. There'll be some increased out-of-pocket expense, for example, will reduce that number. Things like that. Maybe Kristen, or sorry,
I'm
Kirsten,
confused. I'll wait to the next round maybe to see the numbers.
Yeah, no worries. Kirsten, you want to say something about what I'm saying?
No, I just want to let
Go ahead.
Robert and Tony and Misty know that we know what you're asking for. I think the difference, Bill, a little bit is the difference between messaging specifically around GLP-1 drug coverage versus messaging around the 3.4% overall path, and being able to say specifically about GLP-1, here's what this means for you in terms of the trade-off. The dollar impact specifically for this one benefit might be $30 PEPM, or a $400 deductible increase, or a $25 copay increase, which is something that's separate from the overall path of how we get to 3.4% when all is said and done. So that's something that we have part of that answer, and we'll get the rest of that answer together for you all for March.
Yep, that's exactly it. Thank you.
Yeah.
All right. We're a little bit behind. Anybody else have anything they want to say on this particular topic? All right, let's press on. Our new EAP vendor is here to present. 15 minutes. Canopy.
Great, thanks, Bill. Got it. Yeah. Hi, everyone. I'm Umberto Chacon, and thank you for the opportunity to provide a brief update regarding Canopy AP. All of us at Canopy are honored to serve OEB and its members, and we're happy to be here today. So starting mid last year, we worked with the OEB implementation team to transition the EAP to Canopy with a 10-1 launch. So thank you to everybody who helped with that. If we can go down a couple slides, Rose. Oh, agenda is fine. So you can go back up. Up to agenda. You can see we'll go over just some numbers, some feedback, give you an opportunity to give us feedback and ask any questions, and then go from there. So if we can go to the next slide. Kelsey Nordland is my partner supporting OEB entities. We're both your customer success managers, and she'll speak a little bit later. So we can go to the next slide. So just a reminder that Canopy's mission is to create happier and healthier futures by breaking down barriers. And Canopy's been around 50 years now, so have a good track record. We can go to the next slide. Actually, yeah, there we go. So 184 entities chose EAP. This compares to the previous EAP that had 171 entities that chose it. And we're covering 76,000 employees. Previously, there were 74,000 employees that were covered. You can go to the next slide. So we've had a strong start. It's about 5% annualized utilization, which is strong for something that we're kind of relaunching, I think, out there with the entities. So that's where we are now, and we'll see how that tracks over time. You can go to the next slide. That translates to, so far, over 1,300 members have been referred to a service or a provider. So that's what we count as utilization. We don't look at like web hits and things like that. We look at people who actually receive a referral to a provider or service. And then we also looked at how many folks are using the web resources. So there's almost 2,000 unique registered users on the Canopy member site, and they've accessed over 17,000 web resources on the member site. If we can go to the next slide. So I'd show you, so the top presenting counseling issues, we see anxiety is the #1 issue that people are coming to us to see counselors about. And then behind that is marriage and relationship. Those two are the highest, with anxiety about 20% above what the marriage and relationship number is. Then we also have stress, family, and depression. As there's other reasons, but those are the top 5 why people are coming to Canopy for counseling referrals. Go to the next slide. So 44 members have used our in-the-moment phone counseling support. So when members call in, the call center is open 24/7, and the call center is staffed by mental health professionals. If someone has a pressing issue, they can receive in-the-moment consultation right then and there. So people don't necessarily always know that that's available to them, but we have been able to help people with pressing issues right when they call in. Some of those then do receive referrals to counselors. Others, that's sufficient for them. But I just wanted to highlight that as a service that we provide, and people are using that. You can go to the next slide. And we're also available for crisis support after traumatic events like an employee death, something like that. So far, 4 entities have used our CISD services. So, we have been getting the word out about we are available. And once again, that's a 24/7 service. we're able to consult with an entity that's had a traumatic event anytime, and we can very quickly have a counselor available to debrief with a group of employees and or individuals as necessary. So that is available out there. So now I'll hand it over to Kelsey to tell us a little bit more about some of the highlights.
Thank you, Umberto. So in addition to what he highlighted already, we've also provided orientation meetings. We've provided orientation meetings available to all OEB entities. We've also done several for individual entities. So far we're at 13, including open enrollment. Next slide. These are a few quotes from entities. I'll read one of them. So the middle one says, "One of our employees experienced a panic attack upon arriving at work, triggered by an interaction on campus. Thanks to Canopy, the employee was able to immediately connect with a mental health professional. The provider offered valuable support and coping strategies, allowing the employee to regain composure and successfully navigate the rest of their day." This is exactly what our goal is and what we're working towards at Canopy, getting people connected to the care they need when they need it. Next slide. Here you can see our regular email communication with entity contacts that they can forward out to staff. Starting on the left is our monthly promotional topic. The middle one highlights all the free webinars available that month. And then the one on the right is our leadership support email. This is one of my favorite resources we have. It has tips, tricks, and resources geared specifically for leaders, supervisors, and HR. If anyone on this call is not on our mailing list and you want to be, definitely let myself or Umberto know. Next slide. These are a few of our flyers to give you an idea of what some of our promotional materials look like. We've really moved away from a lot of text and kind of, started adding some eye-catching colors, larger images to just help grab people's attention. And all of our materials include our QR code for quick member access to Canopy's resources and benefits. Next slide. Hard copy materials are also available. So the images on this slide are some of our posters that you'll see. We also have wallet cards and brochures available for free to entities in both English and Spanish. They're ordered through canopywell.com or also by reaching out to myself and Umberto. So far, we've provided thousands of materials to entities and really just appreciate the ongoing collaboration to spread the word about Canopy's benefits. Next slide. And this is kind of for both myself and Umberto. Curious if anyone has any questions, any feedback, anything you've maybe heard from entities.
I haven't heard anything, but I like the numbers on engagement in the first 4 months. Very, very interesting. Open to floor to the board. Doesn't look like it. Oh, here's somebody. Tony.
Yeah, this is where I may just be exposing my naivete here as a new board member, but this particular benefit is or isn't something that's available to all OEB covered employees.
Yes, this is a benefit for all. EAP is a benefit for all employees who participate in a plan.
So if an employer participates in OEB by providing services, then all of the employees of that employer have access to this.
If they're in an insured plan, I believe I'm saying this right, and Ollie chime in, but they have to be part of an insured plan.
Yeah, the employer.
You want to say something, Ollie?
Yeah, go ahead.
Yeah, so each entity has to select the EAP. It's offered to them, and then each entity has to select. That's why we see the difference from the previous EAP, where it's 171 chose it, to now it's 184 have chosen EAP. But there are some entities that have not chosen it yet. So.
And those costs
answer your question? Yeah.
It does, thank you. And those costs are borne solely by the entity in this case, or by the members as well?
by the entity. So the entity pays on a per employee per month basis, and then Canopy provides the service for no charge to the member.
Thanks for your patience with my rookie questions.
No worries. Robert.
No, thank you.
Yes, this is anecdotal, but the feedback I'm getting from my members is that Canopy's EAP is so much better than the prior one, and I haven't had, all I've had are satisfied comments regarding Canopy's EAP.
Great, thank you, thanks, appreciate that.
All right, anyone else? Not seeing any hands. So in the previous month, we had a carrier contract. Oh, thank you, Umberto and
Thanks,
Kelsey.
Bill.
Appreciate your
Take care.
time and give us that update.
Bye.
Sorry. So the previous month we had our carriers give up, but we ran out of time on VSP. VSP is here now to give us just their update on their whatever called the plans, right? So 15 minutes for VSP. Please go. Is it Valerie?
Good morning, or sorry,
there you
good
go.
afternoon. Thank you for the opportunity to present to the board. I'm Market Director Valerie Swires, and I have the pleasure of managing our relationship with OEBB. Today, I have my Regional Vice President, Luis Martinez, on the line with me, and who oversees the Pacific Northwest region, as well as Vice President and Clinical and Medical Affairs, Dr. Val. They will be providing a small sampling of how VSP has been the driving force of innovation, of innovating vision care for 70 years. In 1955, 9 optometrists incorporated California Vision Services with the commitment to community and providing access to affordable vision care. Their dream was to promote an annual eye exam by contracting with a network of doctors to offer discounted rates that they could sell to employers. 70 years later, we have 60,000 clients, 88 million members. That's 1 in 4 have VSP. And in 1976, our name changed to VSP. And in 1984, VSP started offering a national network made up of private practice providers. But today we have the largest network of providers with 121,000 access points, including private practice, national retail chains like Costco, Walmart, VisionWorks, and even iconic.com, our online retail website where members can shop online and use their benefits to purchase glasses as well as contacts. This was launched in 2011, and this last August, we hit a major milestone of a 2 millionth order being sent. And in 2024, OEBB had 462 iconic claims, a little over $65,000 spent on iconic. And most recently, we acquired iMart Express, and they have 5 locations. Currently, or for 2024, they were your number 3 out-of-network provider. They have areas in more rural areas like Bend, Eugene, Medford, Roseburg, and Corvallis. We're really excited to have them joining our network. And while we've grown, our overall purpose remains, and that is to empower human potential through sight and provide equitable access to vision care. In 1997, VSP launched our charitable program, Eyes of Hope, and in 2023, we hit a milestone of providing 4 million people in need with access to no-cost eyewear as well as eye care. And since inception through June of 2024, VSP Vision has invested nearly $3.3 million of that in to provide free eye care and eyewear to people in the state of Oregon. We launched our mobile VSP Eyes of Hope charitable mobile clinics in 2009, and we have visited the state 35 times in partnership with local nonprofits. I've had the pleasure of volunteering for 5 of these events, and I can't tell you how impactful it is to see someone pick out a pair of glasses and put them on and be able to see clearly. Their faces just light up. I recall one person saying they had not been able to read a book in 10 years and that they couldn't wait to read again. And while we can't use our charitable mobile services for insured members located in healthcare deserts, we have used this concept and partnered with a vendor called Onsite Eyes to host a 3-day mobile clinic in 2023 and 2024 for PEB and OEB members in Coos County, Oregon, at the Mill Casino. We provided a total of 141 exams with these 2 events, and we dispensed 88 pairs of glasses. We are approved to fund a clinic in 2025, and we're working with both PEB and OEB staff to plan this event. So we're really excited about all that we've been able to do around our network. I'm going to hand this off to Luis Martinez to share how our Global Innovation Center is helping VSP reimagine the future of eye care and eyewear.
Thank you, Valerie. Nice to see everybody. It's great to see the history, right? The last 70 years of providing eye care to the marketplace. And we just want to make sure that we're around for 70 more years. And I wanted to talk a little bit about the VSP Global Innovation Center, which is where it all starts. This is an arm of VSP that is focused on reimagining how eye care and eyewear are delivered to the world. And we have an outside-in approach at the GIC. We're looking outside of our corporate boundaries, and we're looking to the startup companies, the innovators, and all the emerging tech that's out there, and trying to plug into that ecosystem so that we can be shapers of the industry going forward. And anything done at what we call the GIC is focused on 3 pillars: health equity, sustainability, and the patient experience. And if you look at this slide here, there's a couple of examples of those. One I'll point out is the box in the middle of the screen, which is where we ship all of our iconic orders. And that box is 100% made from recyclable materials, non-toxic ink, 0 plastic, and it's reducing materials usage by 65%. So just one way, right, that VSP's Global Innovation Center has made a difference when it comes to sustainability. The other example is around patient experience. And you see on that iPad and that smartphone, that's an example of what we call the VSP and You quiz. The GIC tells us that the world has been gamified and people want a personalized digital experience when they're making decisions about their benefits. So we launched the VSP and You quiz in 2023, actually launched it at South by Southwest in Austin, Texas, which is one of the largest innovator conferences out there. And this quiz, in under 2 minutes when you take it, gives you a personalized recommendation about how you can leverage your VSP plan depending on your lifestyle, your hobbies, and the needs of your family. So some pretty cool things that we just wanted to touch on. You can scan the QR code if you're interested in learning more, or you can visit VSPvision/innovation. The next slide here, just wanted to talk and quickly spotlight 3 future trends that are happening in the market. Obviously, healthcare deserts are something that we're all familiar with. And what we're starting to see with some of these startup companies is the design of these visual and AR headsets that are being used to address healthcare deserts, low-staffed eye doctor locations, where we believe that they can do digital eye exams. So we're watching a company called Hiru, and we're in pilot with them right now at some of our VisionWorks locations to do some of the pre-testing before the patient goes to see the doctor. And we think there's a real application going forward, potentially to address healthcare deserts and low-staffed practices. The middle one is around, we believe that eye care can be an early adopter of generative AI. And what we mean by that is the eye has always been a window into overall health and wellness. But we believe with AI and some of these advances with the devices like retinal screening machines, that window is going to expand into a skylight. And in fact, there's already companies out there that through the course of an eye exam, not only can you see if the patient's at risk for hypertension and diabetes, but things like cardiovascular disease, kidney disease, potentially early stage Alzheimer's, all through the course of an eye exam. So we're watching startup companies. One of them is Toku Eyes. They've actually developed software to assess heart risk through a retinal scan. So some of you know retinal screening coverage is available at a cost-controlled price to all VSP members. There's also the ability to cover that as part of the core benefit. So we could certainly talk more about that. And then the last thing I'll touch on before we open it up for some final thoughts and questions is how accessibility is a bridge to smart eyewear adoption. So when we think of accessibility or potentially people living with some sort of disability, for us, we think about what we call low vision, which is partial blindness. 7 million Americans live with low vision today, and we see some application with smart eyewear to potentially solve for that. So we're all familiar with things like the Apple Vision Pro and the Meta Ray-Ban Story glasses. We believe in the future, those things are going to be probably part of a benefits package. And we believe the doorway into that potentially is accessibility. So this company that we're highlighting, eSight, is a company we're watching. They have a headset that will reduce that legal blindness and produce a 20/20 vision experience for the patient. So right now we are in the pilot phase of working with some of our high-tech clients in the Silicon Valley to potentially produce a benefit integrated feature of their plan to cover their smart eyewear device. So those are a few things. We only had a brief moment to touch on, but happy to come back and discuss more and happy to pause there and take any questions or comments. We also have Dr. Valerie Shidi-Pilon with us, who's our Clinical Affairs Director. So any questions, she'd be happy to answer as well.
I open the floor for questions from the board. I want something that's just plain and actually low tech. You know, we all know that with a CCD camera at night, you can take a picture and it's almost like daytime. So why do we still have to put the world's brightest white light through a 1-inch lens in front of my eyes once a year, blinding the crap out of me, when we can get something that can see better, right? Why can't we just do something simple like that? Right.
I wish it was that simple, you know. So that's why we are putting you in a dark room and quickly be able to capture the retinal imaging, because what happens is your pupil starts to adjust to illumination and light. So sometimes that's why we put our dilating drops in our patients, so we could control the pupil size. So we were able to evaluate the retinal structures behind the eye, the optic nerve, and the blood vessels. So maybe in due time, there is new technology coming out, handheld technology, retinal devices that are a little bit softer with the illumination, but you know, hopefully as innovation grows and AI technology comes out and we're able to do things with the natural pupil size without capturing with bright lights.
But now, you know, thanks to my VSP coverage, I get my eyes examined once a year.
I love that. You keep it up. Make sure you get the word around, especially if you're living with, you know, systemic conditions like diabetes or hypertension or high cholesterol. The retinal imaging and those retinal evaluations, a part of the well vision exam, is critical for our population set. So thank you.
Questions from the board? Appreciate the update. Love the work that VSP does in research and technology, and definitely all the philanthropy that you all do, especially in the state of Oregon. Appreciate you presenting all that. It was very nice. Thank you.
Thank you.
Thank you. Have a lovely evening.
Yes. Bye-bye.
On to Public comment. Any public comment, Rose?
No, no public comments.
Other business comments from board members? Open floor? All good? Sally.
Yeah, I have one quick question. There was our licensed benefits coordinator had a conversation with an employee of a different school district who is under OEB, and they are in a MOTA plan. And they were told they are currently undergoing cancer treatment, and they were told that if they switched to a different job and got a MOTA plan in that job, that MOTA would not cover their cancer treatments for a year. And I'm curious if the board is aware of anything like that.
You mean a job that then is covered
actual-
outside of OEB? Is that what you're, is that the
No,
correct?
from OEB to OEB, MOTA to MOTA.
Oh. But they'll have open enrollment due to a life change when they change jobs, right? So
Yeah. I mean, you know, if
I-
they left their district and went to another school district, had MOTA again, they were told by MOTA that their cancer treatments wouldn't be covered for a year.
I think we can pass this over to Cindy, right? And let
Yeah,
Cindy.
we can track that down, Sally.
Okay.
Yeah, I don't know if there's like a waiting period. I mean, I don't think.
No,
I think
there's
there's
no more.
generally a handoff. Yeah, that doesn't
Yeah,
sound.
I've never heard of
Doesn't sound
anything
right.
like that. So I said I would
Yeah.
go ahead and ask the board, and we, you know,
Yeah.
kind of.
Let's let OEB staff respond to you directly on
Okay.
that.
Yeah.
Based on
Yeah, we
your
got that.
criteria. Okay.
That sounds
So
good.
please, I'll have one of your people reach
Sally.
out to Sally, right?
Okay.
Thanks,
I
Sally,
saw
this is-
somebody's hand went up and then it disappeared.
That was my
who-
hand.
Oh, that was your hand. Okay, got you.
Yeah.
Okay.
All right. Thank you, guys.
Okay. Anybody else have any comments for the good of the order? If not, I'll just say good meeting. And next week, I'm rushing this. Next month, the numbers will be coming at us big time. So be prayer. March is our first round of looking at lots and lots of detailed numbers for our April decision-making process. So be ready for lots of that when we come around. So you'll get your packet early and just scan through all that and have your thoughts in order. Appreciate everybody's time as always. Thanks again for being on the board. Thanks for all you do. And thanks. See you in a month.
Thank you, Bill. Thanks, everyone.
Bye.
Thank you.